Maybe it's just rubber. Very small. Sorry, guys. Worst thing ever. You what? Oh, first game. Well, this I got my little double I was not with you. I'm gonna actually do it. That wasn't fun.
Started off right. Started off right. All right, so everybody can hear me okay? It's I wanted to give you guys an overview today. What we're going to do is a busy day. Kind of like our very first day of class. We had 3 PowerPoints today. Today is similar to that, okay? And so we're going to get through these OB comps that are really fun to talk about and kind of exciting. Some of these things that are rare, but then that we actually will, if we see it, we got to act fast and start learning how. Do I need more assessments? Or can I call the provider? More of that kind of stuff today, okay? So I can start honing that kind of skill and for you, okay? Then we're going to move to pain medications, the pain modalities, right? And then we're going to hopefully finish off with the EFM key. I got a few emails around that. There are some questions on that, but I'm only going to be testing you at this very, very high level. It's not going to be at the minutia. I get you in the minutia a little bit on that, on the key, on doing and analyzing some of the stuff. But when you go into OB, I'm not asking you to do that, right? You're not going to be documenting an OB. It's all observation, okay? So that's going to be the big thing here. So I'm going to kind of bring it out and give it context for you, all right? It's going to be important for you to have that. So 3 things we're going to get through. We're going to go and start with our Kahoot today, okay, to see how much we retained from last week, all right? And somehow I think why is that up there? Shouldn't have that up.
What's that?
Oh, we need on there.
Yeah.
We've got something else up there that we probably shouldn't have.
No, we're good.
I should be televising from here.
And you are for us. But for some reason you're seeing mine.
Okay. Yeah, just let's stay on the Kahoot. All right, we'll get started. Let's see, there we go.
Oh, now I get it. I don't get it. I was like,
For about 10 months to a week. Locked in over here.
haven't registered. She's waiting for people to register. No, Ellen.
Go flying.
What did you say? Alright, we'll get started. We'll take our stand up in 5
Don't you just feel wanted?
Alright, what is the likely diagnosis? 26 gestation, a BP of 156/94, no proteinuria. Good. Alright. Those of you that thought preeclampsia, tell me a little bit about that. What is present when you have preeclampsia on this diagnosis? Who can tell me? Say it loud. Protein, right? From Rochester, we're saying protein, right? But it says no proteinuria. That's the only difference, right? We've got after 20 weeks, right? So we know that it has to be gestational. The only time that it's going to be, chronic is when? Who can tell me? When is it chronic hypertension? Okay, it can be that, but what is the gestational age? Everybody should say it loud, pretty loud, even in the Twin Cities.
Before 20 weeks.
Less than 20 weeks, okay? So if you see, and why is that? The physiology around this, I'll just repeat it again, is that blood pressure is normal in the first trimester and it slightly goes down in the second. So anytime someone breaks through on a high blood pressure in the second trimester, we know something else is going on, okay? And it returns back to normal by the third trimester. Okay, so someone breaks through with a high blood pressure and we didn't get a good blood pressure in that first trimester, we know that there's something else going on. People that are just normal and all of a sudden crank higher in the after 20 weeks, we know that there's an issue as well. So that's why it's gestational. Okay? So before 20 weeks chronic, after 20 weeks gestational. All right? And then we add in the other things, proteinuria, okay? Stuff like that. Okay? Then it becomes preeclampsia or superimposed or eclampsia. What's eclampsia? Seizures. What do we usually use to protect people from? What's the medicine we give them? Magnesium sulfate. Excellent. Okay? Very, very good. It's protective, right? What does it usually do? What's its mechanism of action, magnesium sulfate? Smooth muscle relaxant, right? So it's a secondary effect, right? Is the uterus a muscle? Right. Relaxes the uterus. That's cool. So no more contractions. That really works well when we use it for preterm labor. But we're really looking at it for the arterials, right? We want to make sure that those relax. They're smooth muscle too. That's what I'm trying to do. Relax them so that I don't cause some sort of, seizure. All right? That's what we're working on. Mom feels horrible. Okay? Really horrible. She's very relaxed. Very relaxed. Has a headache. Baby feels not great either. Not a nice medicine, but very protective. Okay? All right. So if you're studying, go through that together. That's what I want you to do. Kind of walk through. What does it do? Why is it used? Okay? Does that make sense? Good. All right, let's go to the next. Fungi. Beta's not for me. Come on, babies are for everyone. All right. Which infant is at risk for hypoglycemia?
What?
Excellent. Oh, okay, good. So a few of you thought cesarean section birth, okay? Now, sometimes that'll happen, right? But it's not necessarily a main risk factor. Mainly just a large for gestational age baby. Okay, why is that? Because they're being fed, right? Spontaneously fed by the placenta. And they come out, if they don't feed within an hour, right, they're at risk. But some people might think, well, with a cesarean section, do they get to feed right away? Sometimes that might be at risk, but it's not the main thing that's at risk. So if you're looking at the right answer, you have two there. You're going to have to say to yourself, which one's the best right answer? Okay? See that? Yeah. Okay. Who's Galentine's Day? That's you. A parent asks why his newborn arm. What is their response?
Yeah, which one? What are two ones?
I don't know. I'm not looking for
One,
it.
two, three. What?
Either way, it has to be yellow or whatever way you go, I think.
I knew that word.
I'm not good
All
at
right.
right.
Oh, no.
Okay.
Good.
It's like,
A lot of you got that right. Okay. Just, she may, okay. A couple different things, okay? When you think about this, I mean, obviously, are babies able to shiver? No. So you kind of have to answer it from there. There's a couple different things on this, and most of you got it right, but you had to combine this. So just really study the reasons behind why a baby might have that, okay? Because we have a couple different things. We've got reflexes going on. We have possibly a sugar condition. Maybe we have even cold stress. Okay? So you have to kind of think through that. Right? All right. Really these out. 2 and 3.
That's some.
What amount of blood after graduation Good. Okay. So we had a bit of an update from that when Audrey spoke, right? And so some hospitals are still using this 500. That's the only reason why I bring that in. But for the most part, people will say that 1,000 cc's or greater on either a vaginal birth or a C-section is a postpartum hemorrhage. Okay, but we only bring this forward because you might have a couple people that are still at some hospitals saying 500 for a vaginal and 1,000 for a C-section. Okay, they're catching up. Why is that? Because it used to be estimated, an estimated blood loss, EBL. But now it's more quantitative, right? We're actually weighing it, right? And what we found is when we weigh it, it's more closer to 1,000 cc's, right? And we don't want to put people on protocols for just 500. And the other thought is, why would we determine a hemorrhage as less than for a vaginal birth and more than for a cesarean section? It's still blood loss, right? I mean, it doesn't make sense. And so a lot of us said this the whole time. Why are we determining two different? Just because of surgery, it's different? Blood loss is blood loss, okay? That's why they moved to 1,000 cc's. So if you see that on some of your orders, I just wanted you to be cognizant of that, okay? Those are that are in OB. Mm-hmm. All right. Good job on that one. 500 at some hospitals. Most hospitals are moving towards 1,000 for vaginal and for C-section. When would a nurse anticipate that an infant would require resuscitation?
Many weeks.
Good. Okay. Now let's talk a little bit about reasons for possible resuscitation. I'm going to go over a little bit of that today too. At 34 weeks, we're going to anticipate it, but most babies do just fine. A couple of different things I want to remind you. The lungs are matured and starting to be matured right around 33, 34 weeks. Okay. How is that done? The infant actually urinates and drinks the fluid. And what the fetus is doing, it's drinking two different types of proteins. Okay, lecithin and sphygmomyelin. Okay, they mature the lungs. Okay, but some babies are so stressed early on in utero that starts to happen a little bit sooner. So some babies, even at 34 weeks, do not require it, but we anticipate it. And that term is what we use, anticipating resuscitation. We'll get a team in place. We'll have neonatology, possibly, but mainly just maybe a neonatal nurse practitioner. We'll have people that are able to do resuscitation techniques. Also with the labor and delivery nurse. Okay, so there'll be a whole team that comes. I want to hear about births too, if anybody's had any births. So we'll talk about that too. So just keeping that in mind. Now, when you think about a diabetic, some of you put that, not always, and I want to think through that. Why would anybody think that a diabetic might require resuscitation? Because there are a couple reasons for that, and I want to hear if anybody was thinking that. Anybody in the Twin Cities chose that based on some physiology?
Nobody that's owning up to it.
Okay. Well, it's actually a pretty good thought process. It's not the best answer, but it is one of the an okay answer. Anybody here in the Rochester campus want to? Yes, go ahead.
I didn't choose that one, but like when I'm thinking about it, maybe because like if they're larger, they have C-section.
Okay.
And if they get a C-section, they're not going through the natural process like they have to do it out of their lungs.
Yeah, that could be one thought, but there's actually some physiology. Babies that are diabetic, for some reason, because of the sugar, do not mature their lungs as fast. So lecithin and sphygmyelin is low. We don't know really why, so we anticipate and can anticipate on a diabetic that they might require resuscitation in around like 35, 36, 37. Okay? If a baby is not doing well and a mom says she's preeclamptic and also diabetic, this is one of those cases that we will do an amniocentesis to look at lung maturity and measure the LS ratio because we want to see how much the lungs are mature. If they get a check mark and say, yep, we can do it, we will probably go ahead and C-section them. So thinking about that, okay? So that's a good thought process. For whatever reason, sugar is pretty harsh in a lot of environments. And so in this environment, babies just don't mature as fast, all right? So it's an interesting one. So I wanted to make sure to give credit if somebody else knew that. All right, I think we have one more. No, two more. Okay. It's kind of an NCLEX style question. What is the priority nursing assessment in a suspected abruption? What's the priority? Excellent. Okay. Awesome. All right. So some of you did pick a couple of them, but most of you did the right answer. Now, what you're going to do, why is that important? Can somebody tell me what's the first thing that happens with an abruption of the placenta? Baby starts getting its nutrients, right? Mainly an oxygen issue, right? So if you thought about sort of the priority, what you're going to do, it's a little bit simultaneous, but you for sure are going to get your fetal heart rate right away. So if a woman comes in and she's bleeding, the first thing that you're going to do is put her on the monitor and make sure that that baby's alive. Things are different if the baby is not alive. We do things differently if the baby is already not alive anymore, okay? So if the baby's alive, we're going to do things a little bit differently in an environment where we have to do a C-section, all right? So we're going to assess that first. And then we're going to get what? What would you do right away after that? If she's losing blood, what would you do next? You would, but you at the same time, what would you be doing to save her life? She's just come into your triage. This is like an emergency room situation. You get her on the monitor. You call in all your friends. What's the next thing you're going to do?
Start an IV.
Start an IV, absolutely, because this is a woman that can bleed out very, very quickly. So we're worried about mom, and we're worried about baby here. We don't have much time, especially in a percentage of an abruption, anywhere from 20 to 30%. Someone's bleeding actively, and their belly's filling up with blood. This is a huge. Okay? Then we're going to be measuring the blood loss. We're going to be weighing pads. We're going to be doing those kinds of things. Make sense? Okay? We wouldn't be giving terbutaline in this case, okay? Because that would contract the uterus. That would be very bad. Got it? Okay. Last one. Okay, good. What is the priority action in a woman that has a blood pressure of 182/95? Wonderful. Many people responding. Was that because you didn't know, or because we didn't give you enough time?
Right?
People who didn't respond. All right, so there are a few slides that we talk about this, right? IV labetalol is the drug of choice, okay? It is a PRN medication, so when someone comes in with a blood pressure like this, what's our first main concern that's going to happen? We don't know how long they've been walking around like this. We don't quite know. We're going to look at a couple different signs and symptoms. So if you're a nurse, you're in triage, or you walk into a room and someone's got a blood pressure like this, what's your first thought? let's go in the Twin Cities. What's your first thought that you are going to start preparing for? Anybody in the Twin Cities? What are we worried about? High blood pressure.
Seizures?
We're worried about seizures, yeah. We're worried about seizures. This is a very interesting diagnosis. So are we going to go and give her a ton of labetalol? We're going to push it real fast? What do you think we're going to do? If we've got a baby as well that we're considering, got a high blood pressure like this, what would we do? Nope, not a drip. Good thought. Your anesthesia friends are going to be with you, most likely, but you're responsible for this medication. What would you do? Give it fast?
Slow.
Very slow, okay? So if you're walking around with a high blood pressure and someone who brings you down to 120/70, what's going to happen? What's going to happen to that baby? It's very similar to what happens with an epidural.
Everything slows down.
Everything opens up, right? Kind of bottom out. So like the baby's heart rate's going to go down. Mom's going to get really oozy, right? Okay, so we go very, very slow. It's a very potent medication, and we go very slow on it. It's still one of those medications that's within your scope of practice to know, okay? And so that's why we bring it up here. So you're going to bring that blood pressure down very, very slowly, okay? You're going to be calling in your friends. You're going to be talking to them about, we want to make sure that we have, a seizure precautions. And what's the next thing we're going to do? What other med are we going to get on board? We're going to start thinking about, starts with an M. We already talked about it. Magnesium sulfate. Why are we doing it? Help with it. It's going to help relax those smooth muscles, all those arterioles, all the venous structures. And we're going to do that to start protecting her from a seizure. Yes?
Just a question. All right, we have a pregnant mom that's caring, but then with those numbers and those numbers on a regular person, I would be concerned with strokes.
Yeah, exactly.
So
Seizure,
why
stroke.
is it different? Why you wouldn't have that up there? Is it just because she's carrying a baby?
Yes. Yeah. Well, I mean, what we're going to do. Well, we're going to be anticipating stroke, which is really partly, part a cause of seizure, right? We're going to think of all of those different things. The issue around all of this is, yes, you have this another person in there, and the milieu of the baby, the blood pressure of the placenta can equal the blood pressure of the mother, but for most of the time, that blood pressure is pretty stable. It's amazing. It's not until the placenta gets really, really old until it starts to really function funny. And we can do the blood pressure of the placenta by doing Doppler flow studies. It's very, very cool. It's measured in the same way that we do on the arms, in millimeters of mercury. Okay, and it's blood flow that goes in and out, so that the blood pressure of the placenta is present, right? We know that. We know the exchange is that. Okay, so if we affect mom, we're going to affect baby. Great question.
This is preeclampsia?
Not at this point, because this is what we'll do. So if we got this, we got somebody showing up, I'm going to get the IV labetalol first. I want to get that protected first. Then I'm going to be calling in for somebody to help me with labs. I'm going to pull all the labs, all the preeclampsia labs, ALT, AST, right? Uric acid, all of that. That's going to come back stat for me within an hour, okay? But I'm still going to get magnesium sulfate on board. I'm going to get her a bolus of magnesium sulfate. It's 1-to-1 nursing. And so we're going to get her stable very, very quickly and watch that baby. Okay? Good questions. All right. Is that helpful? Go ahead. Yes.
There's IV and oral labetalol. What's the cutoff? So when would you switch from oral to IV?
It's mainly given oral. IV. Mainly given IV. Okay. And it depends. Most cases, if someone goes home, I have you're a gestational hypertensive, you deliver your baby, and the placenta is supposed to get rid of sort of this disease, right? But for some reason, you still have a high blood pressure before you leave postpartum. We're going to most likely choose nifedipine. That's going to be our drug of choice orally. Okay, I listed a few for you there. Not something that I'm going to necessarily need you to know. Okay, but it's just listed there so you know what to do. But good question. Right, it's again a smooth muscle relaxant, same way but orally. Okay. Yes. Go ahead.
So IV is preferred.
Yeah. We would not do oral in this case because of emergency. Good. Any other thoughts from the Twin Cities? You good? Okay. Good questions. All right. So now we got everybody's blood moving, because now we're moving into all the complications of OB. Okay. So today's going to be a lot like that. What do we need to gather? Do we need more vital signs? Do we need to do? What do we need to do? We need to get our more information for our SBAR. Then do we need to move on? Okay. So that's what we're going to work through today. All right. So when we think about how we handle medical emergencies, we're going to think about a step-by-step process, okay? And what I'd like to do is really begin to start to have you all thinking about it like that. And if you have a way of just kind of documenting that in your notes, like what I would do first on some of these things, begin to do that, okay? That's what I want you to start thinking through. So we're going to kind of have like one of those kind of working sessions today. And then we're going to move into different ways that we help with labor, both induction and augmentation, and sort of those complications as well. Okay? So we've got intrapartum complications that resulting in some things, and then also labor complications. We'll move into fetal monitoring.
Are we
First
with
comp.
just the slides up, or do you want to see?
Are you guys good?
Yep,
Twin
we're good.
Cities? Okay. So we're going to talk about two different things, group beta strep and chorioamnionitis, and we do call it triple I. You might hear that on the labor and delivery unit, okay? So we'll start with group beta strep because often it leads to chorioamnionitis. We've referred to it a couple different times in a few other lectures, but I'm just going to go over it a little bit. It is the leading cause of early onset sepsis in neonates. It can cause stillbirth, pneumonia, meningitis, sepsis, and then death. What happens in this sort of colonization is that women don't know they have it. Okay, so 10 to 30% of women are carriers of this. It comes and goes. A couple things to remember about it. Group beta strep is colonized in the rectum. Okay, normal. Okay, what happens is it travels then from the rectum up through the vagina. Okay, and it can infect the baby that way. Now, because it comes and goes, you might be able to isolate it at one time of the pregnancy and maybe not in another. We only test it at 36 weeks. Why? Because we know that she's getting close to delivery, and I'm going to need to treat her if necessary. Okay? The only way to treat it is through antibiotics. And the best way that we know to be treated so that it does not infect the baby is to treat her adequately, and I'll talk about that in labor. And there's 2 doses they have to get. 1 dose they get, and then 4 hours later they get another. So we will actually postpone birth in order to get this antibiotics in if we can. Well, even if we think they need to be ruptured, their membranes, we will delay that so that they can have this medication. It's that serious to infants, okay, that are born with this or exposed to it. Okay? By doing a GBS protocol like this, it does reduce the incidence of infection by about 80%. Okay? As long as they're treated adequately. If not, they will be put on a protocol. And so some of you might see that on the postpartum unit, that a baby's on a GBS protocol. It means more vital signs, closer watch. Sometimes they'll even get antibiotics back in the NICU or in the special care nursery. Okay? All right. Again, it's a rectovaginal swab. Okay? The ways that we will treat the reasons is if some other time a woman was not only positive for it, but then they had a GBS infection either in pregnancy or that baby had one. Okay, that would be indicated for the next one, right? We don't mess around with it, all right? If they had a GBS urinary tract infection, okay, during that pregnancy, we'll treat it adequately, but we will treat her as infectious, that has been exposed, okay? So she will get antibiotics in labor, no matter what, even if I rectovaginal swabbed her, and it was negative. Okay, so that buys her definitely antibiotics in labor. If she comes in labor and she missed her 36-week appointment or a 37-week appointment, and we don't have a known GBS swab, we will treat her as if she's positive. Okay, so we'll give her antibiotics. Okay, and then we will give antibiotics if she has a known temperature or if she's been ruptured longer than 18 hours. Anytime someone's had a bag of water ruptured longer than 18 hours, they're at a high risk of infection for that baby and for the chorion and the amnion around that baby. Okay, so even the mom's at risk for infection. How do we treat it? The way that we treat it, the drug of choice is going to be penicillin. Okay, and there's a couple different ways we can treat it if somebody's allergic to penicillin. Okay, but the drug of choice is going to be IV drug of choice, antibiotic, penicillin. All right? And the way that we do it again is we give it right when they come in and then right 4 hours later. I've had GBS twice out of my 4 births. So on my last one, because I go so fast once my bag of water ruptures, they waited on me to rupture my bag. So I was in labor. And so I would try to get through at least 4 hours, okay, of labor so that my youngest Gracie was protected. And then I went on a GBS protocol as well, okay, just to make sure. I want to make sure she was safe. Why was that? Because when I was in the military back in 1998, I was a postpartum nurse at that time. And it was my first time I had ever seen GBS, but we didn't know about it that much back then. It was something that we were hearing that might be this cause for this unknown sort of rapid infection that was killing babies. I had a baby that was totally fine. I was on nights, and then luckily I got that baby, that couplet, back again that next night, and I noticed that this baby looked totally different. Wasn't eating well, had a high temperature, respiratory rate was going up, heart rate was going up. Okay. I ended up taking that baby and getting that baby admitted to the NICU by the end of the night. The baby was already very, very sick. That was just 36 hours after birth. Okay? Unfortunately, that baby did not live. Okay? So that's how fast it happened, right? And it was group beta strep. So that was a big thing for me. So anytime I had it in labor, right, I made sure, and I watched those babies very quickly. Now, there's some times that you can have a late onset group beta strep. It's very rare. And so when I, knew of this and I knew too much as a nurse midwife, I watched them for that whole 2 weeks. Okay, I really watched them for infection. Okay, all right. Now, when is it not indicated? You can think about this just from the physiology of it. If the bag of water isn't ruptured, right, and they have a planned C-section with no labor, would I give them antibiotics? Who thinks I would? No, we wouldn't. Why is that? Well, antibiotics are pretty stressful on the milieu, the flora of that baby's gut. Okay? So we don't want to give antibiotics unless we absolutely have to. All right? So we're not going to do it unless we know that there has been some labor or the bag of water has been ruptured. All right. Good. Choreo. Okay? What is the leading cause of choreo? There's a couple different things. E. coli, group beta strep, all of these nasty things that are colonizing the rectum. Okay? What happens is because, the vagina is ascending, right? So we know that things are going to go up and down and, with intercourse and all sorts of things, right? It's a self-cleaning organ, right? We're not going to clean that, right? It's not like it needs to be something that we ongoing do anything on that. It should take care of itself. However, sometimes if you've got an open cervix, right? Or you've got a ruptured bag of water that's too long, you can get choreo, okay? Or triple I. And what happens is, the main thing that happens is a mom spikes a temp, and then the heart rate goes up. Okay, so anytime a baby's heart rate is greater than, what's the upper limits of a heart rate of a baby? Good, 160, okay? Anytime a baby goes up in 160, right, and higher, what we have to start thinking is, where is the mechanism of the infection? Is the baby infected? Is the mom infected, right? So if the heart rate goes up on its own and mom has no temperature, right? Maybe the baby's infected, but for the most part, usually it's a double thing. Mom's got a heart rate that goes up, got a temperature that goes up, then that's going to be, the next thing that's going to happen is the heart rate. The fetal heart rate will go up, and that'll tell us that the baby's infected. All right? All right, so we get temperature first, and then one of the following. White blood count of greater than 15,000. Now, any of you guys that are sitting at anything greater than 10 or 12, we're going to think something's going on. But with a mom, remember, it's an autoimmune response being pregnant, so her white blood count is going to be high. Our cutoff for this is 15. Some people that have no infection might be a little higher, but for this, if she has a white blood count of greater than 15, we're going to consider that an infection because she's already got a temperature as well. Maternal heart rate of greater than 100. a heart rate greater than 60, and if she has any sort of tender uterus or foul-smelling fluid. Okay, and so one of the things that we've been talking about is when do you know that you know that you know something? When you're a labor and delivery nurse, when you go into a room and someone has an infection of their uterus, you will never forget that smell. Okay? And the hard thing is, as a labor and delivery nurse, you can't leave that room very often. So it kind of stays with you. And the reason why it stays with you is because it's group beta strep or E. coli. And those infections smell. Okay? And so when it happens to you the next time, you're like, oh yeah, I know what this is. Okay? Also, when you do a vaginal exam, that when you actually, even through your glove, that whole area, because the core, right, the vagina is a core temperature, very hot. Okay, this woman is burning up usually. So it's a couple different indications where you're thinking, maybe I haven't seen the temperature yet, but I can make these assessments. Okay, a lot of labor and delivery is just putting it all together. All right, that's how you diagnose that. All right, so we're going to do lots of vital signs. Right? She's going to be kicked up, and maybe every hour at least. We're going to educate her and let her know that we're going to be doing 2 different types of antibiotics on her. And so that's going to hopefully take care of her infection and then also take care of the baby's potential. We're going to watch for endometritis. Remember, the endometrium is where that placenta attaches. It's the lining of the uterus. So endometritis, that uterus might get infected. A urinary tract infection, and then obviously looking for sepsis. All right. So a woman that comes in that's highly infected and before we even start labor, is at a high risk for a couple different things, right? And that it's not only that the uterus isn't going to work all that well, but also she's at a high risk for bleeding disorders as well, DIC. Okay, so she's got a large infection that's systemic at this point. Her clotting factors, her immune response, all of that might be affected as well. So you're watching for lots of different things. Okay, some people are always shocked, thinking, "Oh, she came in and she had an infection. Why did she go into DIC so quick?" It was the infection. Okay, so it's usually shocking, but it is one of those causes for DIC. Just a nice picture. Green meaning gooey infection. So just watching. So that baby is just lying in that nice, pretty little sack, and all these drinking all that wonderful fluid. Okay. By this time, you'll see some breath movements at close to term. Right. So this baby's drinking it in, and it's just going all through its system. Okay. Right, these babies come out with high heart rates, temperature instability, do not feed well, okay, and they're admitted to the NICU usually. Okay. All right, let's talk about the amniotic fluid. We have complications, both too much, okay, oligo, or too little, and too much. Okay. When you think about a normal amount of fluid, think about 1,000 cc's. If you think about a water bottle, right, 1,000 cc's, that's, how many of those would need to be inside, right? But on this one, it's half of it. So only 500 cc's of fluid for that baby to float around in. A couple different reasons for this, right? It might be that the baby's just growth restricted. There could be a post-mature placenta that's not functioning well, so the exchange is not well. That baby's not able to get enough nutrients and then not urinating enough. Okay, could be a lung issue where you've got pulmonary hypoplasia, so you've got small lungs. Could be that the baby's just needing to come out and there's preterm birth risks to that. So that might happen. And it could be that the kidneys aren't functioning properly. All right. When a baby's this stressed, it might do what we all hope it's going to do just to let us know that it's stressed, is have meconium fluid. I like to know if a baby's stressed, okay? Most babies will let us know by pooping too soon in their fluid, right? When you feel stressed, what happens to your tummy, right? Right before a test, right? Some of you might feel that way. It's the same thing with a baby. It knows when it's stressed, okay? It knows when it's stressed, and it'll let us know. That is not a great thing, however, to take care of the baby post-birth, right? When it already has meconium fluid, we know it's stressed. We don't know how long it's been drinking that, so we're going to really watch it. Meconium is very gooey. How many of you have seen meconium? Yeah, right? So it's very gooey, and so when it gets into the lungs, it's just that as well. It just attaches to the lungs, hard to get out. Those babies go to the NICU, all right? Now, another concerning thing with low fluid is cord compression. Because of the wart and jelly that's surrounding the cord needs to float in order to function properly. Now, sometimes you go in and you'll see cords that are wrapped around the baby's body and even wrapped around the neck, but it's able to still have enough fluid to actually do what it needs to do. That's totally fine. This is different. If you have too little fluid or a pocket of fluid that's missing and that cord is laying and alongside the baby, it'll really wreak havoc on that cord, and you'll see that in the fetal monitoring strip. Okay? So when you went over your fetal monitoring strips, you'll see that when there's cord compression, there's some things that happen to the baby's heart rate with contractions. Okay? And we'll go over those a little bit. All right, what can you do? You can replace the fluid. It's called an amnio infusion. There's a way to insert this. It's a catheter that's inserted through the vagina. You have to have a ruptured bag of water, and you deliver the fluid that way. It's called an intrauterine pressure catheter. Okay? If you think about back to Care Families 1, we talked about this. There's external monitors, and then there's internal monitors. The internal monitors, one's called an IUPC, intrauterine pressure catheter. The other one's called a FSE, right? Fetal scalp electrode. FSE, yeah, fetal scalp electrode. Okay, and it's attached to the baby's head. Those are very accurate. Okay, but our external ones work really well as well. You can't deliver fluid unless I've got an IUPC in. This used to be done quite frequently when we saw meconium stained fluid or when we had low fluid. With my daughter Sophie, she's my third. I was living in Europe at that time I was living in England, and I didn't have a car, and so I had two other kids. And so what happened was I would walk every day to school to take these kids. So I had school run. Okay, one trip while pregnant was 1.5 miles. Okay, and back, so 3 miles just for school run. Then I had to do grocery shopping. Okay, why is that important? Well, in rain or shine, you're out there, right? I'm pregnant, so my little placenta got really worn out pretty fast because I got there when I was about 22 weeks, and I wasn't used to that much walking. Walked about 5 to 7 miles a day. Placenta got very, very aged, and what happened to Sophie was her fluid started going down. So she had less than 5, okay? We say less than 5 or 500 cc's, okay? And so she had induced because of that. She did just fine. The labor was a little stressful because the placenta was aged at 38 weeks. She did just fine, but those kinds of things happen. It wasn't her lungs at that point. It was her placenta that wasn't functioning well, okay? Sometimes you have to figure out where the origin is. When they pulled that placenta out and it came out, it was very, very calcified, okay? So those are the little dots, remember that we talked about, where if it gets calcified, that exchange isn't happening, right? They're little white dots that happen. If you get more than a grade 2 placenta, which mine was a grade 2, grade 3 at that time, you got some issues, okay? The baby's not getting what it needs, okay? So if he was born at about 38 weeks and 4 days, and she was about 5, I think she was 5'2". She was a little tiny thing, okay? All right, so that's a good story to remember. All right. Any questions about any of that? No. What happened was I was really tiny, and I kept going in for my measurements, and they kept thinking, this baby isn't growing. And I was like, that's weird. I mean, right? So they did an ultrasound, and what they found was the pockets of fluid were low. So it wasn't, and she was pretty good size, but what was happening is because she wasn't having enough fluid, right, around her, she was at a higher risk of having a fetal uterine death, right, from a cord accident.
Right? Something that just happened.
Well, for me, it was because of the aged placenta. Yeah, aged placenta. Yeah, a lot of stress, taking on a lot, living in a different country, right, walking a lot. That could be something that was caused by that. Good question. Yes.
So you wouldn't be able to add amniotic fluid unless
not at that
it's already
point.
Broken, right?
Right. Yeah.
Yes.
Yeah. Good question. Yeah, that was just when they took a look at the overall, just the health and wellness of the placenta. They could see that it was not doing well. They measured the blood pressure of it, all that. So they said, "Yep, it's time for her to be born." Yeah. Yeah.
So they just injected more fluid for the birth.
Good question. Yes. Good question. So what happens is they inject a little bit of fluid and it starts to surround the baby, and the cord starts to float a little. Okay. When the cord's able to float, it actually then can do what it needs to do, and the exchange can be better. When you have so we're going to talk about cord prolapse today, and the reason why I'm bringing this up now is if you touch the cord, let's say a cord comes out, okay, and it's coming out before the head. My job is to elevate it. Why? Because if you touch that cord or the head touches the cord and it occludes it, what happens to the exchange for the baby? Can't get it. So cord compression can happen with low fluid. Okay? It's just an anomaly of it. We watch that. So what we do is we actually look on and we put the baby on monitors, right? We monitor the baby through the mom, right? And what we'll see is you'll see some funky little monitoring strips of the baby having issues during a contraction. And that's how we know the baby's not doing well.
Is that B cell?
Yeah. Yep. Variable D cells, right? There's earlies, there's lates, and there's variables. Variable D cells just tell me at random times this baby is showing me that it's not doing well. Yes. And it's called a non-stress test. So when I do a non-stress test, I'm talking to you guys, I'm on my monitor. This baby should be bouncing around and doing all these great things, right? But all of a sudden, I'm in this non-stress environment, right? I shouldn't be stressed out, but the baby's having problems. So then if I were to go to stand up or do my 5-mile walk, imagine what Sophie was going through at that time. She had no fluid, right? She was at a high risk of having a fetal death inside the uterus, okay? Yeah.
So you said the bag of water has to be broke in order to do the amnio infusion?
Yeah.
So then when you inject the fluid in, does it?
Great question. So what goes in has to come out. So we monitor the size of the uterus, right? And we monitor the pads of the water that comes out. So good question. So this catheter goes up by their head and it floats all the water around the baby, okay? But then with each contraction, and just like with any water breaking, you're going to have more fluid coming out with each contraction. So we're monitoring that. What goes in must come out, okay? And when we do it for meconium stayed fluid, we don't do it as much for that anymore. Sometimes you'll see it for low fluid, though, just to give that cord a little bit of a break during labor.
So where are you at this point in delivery? I mean, are you in labor or are you in antepartum?
Mostly labor. Mostly labor. We're not going to do an antepartum. That is a good question. And the reason being, if a person has a high leak, which we do see some of those women on antepartum, like a leak that's just happening, but let's say they're 28 weeks. We're going to watch them for infection, and we're going to watch them for fluid. If that placenta is working well, that baby will be fine. That fluid will be recreated, but it'll just leak out just slowly. My sister, younger sister, her bag of water ruptured at 28 weeks, and she made it to 34 and went into spontaneous labor, and her son's fine. Okay, so she didn't have an infection. She just was monitored on the antepartum unit and did well. Yeah. Okay. Any other questions? These are great questions. Okay, so let's keep going. All right, so let's talk about polyhydramnios. Okay, poly. Right, if normal is 1,000, more than that is polyhydramnios, too much fluid. Okay, maybe there's an inability for that baby to swallow. Right, maybe there's problems with heart defect, and RH sensitization can be a risk factor too. Okay, for this. The biggest though for this, and I want you to maybe star this, is diabetes. Why is that? It's the same mechanism that happens for all of us. How do we diagnose people with diabetes? Usually they're urinating too much. Okay? So let's just review diabetes really quickly. You'll go through that whole process in your mind. If someone has diabetes, the mom has diabetes, okay? What happens with insulin? Mom makes insulin. Does it cross the placenta? No, it doesn't cross the placenta. What does the baby then do? Makes all this insulin, hyperinsulinemic. Okay? Why? Because guess what crosses the placenta? Sugar. Big molecule. I'm always shocked when I look at molecules and you think about some of the things that cross over, right? Sugar, by all mechanisms, should not be crossing. But it does. Okay? It crosses over and that baby gets exposed to all this sugar. Not necessarily because the mom's eating horribly, but just because she can't break down the sugar fast enough. All right? So the baby gets exposed to this. And they have the same problems that some of us do when we're first diagnosed with diabetes. We urinate too much. That's the number one cause of polyhydramnios. Okay? Diabetes in the mom. Is the baby labeled a diabetic at this point? No. Okay? Good. What are the risks? Well, you can rupture your bag of water too soon. You can have what we call ureteral placental insufficiency. Large word, but just saying that the uterus and the placenta are not functioning well. Okay? You can have fetal malpresentation, so you've got all this fluid, right? And the baby's just having a happy day, right? And there's a reason why there's not so much fluid towards the end of pregnancy, right? We don't want the baby floating forever. We want the baby to come down to the birth canal. If you got too much fluid, right, the baby's going to have like a shoulder coming down or part of a head coming down, right? They're going to be, it's going to be asynclitic, all right? So malpresentation. You could get this cord prolapse, right? You got all this fluid, right? The baby can't engage because it's still floating. That cord can come down, right? Placental abruption can happen. Preterm birth can happen. Why is that? Well, if you think about the mechanism, the physiology, you got too much fluid in there. What does it tell the brain, right? The fetal cortex, right? And the maternal cortex. I'm ready to deliver. But you're not ready to deliver, all right? All right, so you get lots of pain with this, overstretching. Okay, you get a lot of lower extremity edema. Can have some shortness of breath that's even more than a normal short of breath that a woman already has being pregnant. High risk for postpartum hemorrhage. Tell me why postpartum hemorrhage. I want you to think through the physiologist. I'm going to go in Twin Cities because you guys are talking a lot today, which is excellent. I want my Twin Cities people to chat with me today. Why postpartum hemorrhage on somebody that's got polyhydramnios?
Stretched extra, so it's that much harder to go back down. Clamp down.
Say it a little bit louder.
It's stretched more, so it's like that much harder for it to clamp down.
Excellent. So the number one risk factor of polyhydramnios is postpartum hemorrhage because the uterus is overstretched. Okay? When the uterus is overstretched like that, same with like twin birth, right? The uterus has to think doubly about clamping down. Okay? So when you're thinking about who's at the highest risk of postpartum hemorrhage, start thinking about these cases, right? If someone's in labor, and let's say they're preeclamptic, right? But their labor is just crappy, okay? There's no contractions, right? So they're preeclamptic, so we've got them on magnesium sulfate. All right, what does magnesium sulfate do? Relaxes the uterus. Oh my gosh, I've got a relaxed uterus. What do I need to do? I got to give Pitocin because now I got to have contractions. So you've got all this relaxation happening and all these contractions doing. What do you think happens at the end of birth? Is the uterus confused? The uterus is so confused. Okay, that's somebody that's really high risk, right? So you're kind of figuring out who's at risk, who's at the highest risk of hemorrhage. Okay, stuff like that. Start thinking about those types of scenarios. All right, and because the uterus is overstretched, even without preeclampsia, this uterus does not behave well, even if I give it Pitocin. And the mom's cortex and the fetal cortex, which should kick in pretty well in active labor, doesn't. Okay? So they're at a high risk for C-section. Hypotonic contractions, right? Okay. All right. That's just a nice picture of what it might look like for too much fluid and too little. Now, it's just amazing when you think about babies just all cramped up in that uterus and how well they do, right? Then we deliver them, right, in this big bad world, right? I mean, they're just so cramped as it is, making it through the birth canal. So they already know stress. This is more stress, okay? Corey's laughing at me. All right, now we're going to get into this mechanisms of labor. What kinds of complications can happen in the 4Ps? So if you go back to Care of Families 1, you're going to remember I talked extensively about these 4Ps. We're now going to go into the complications, right? It can be in the powers, right? The contraction power. It can be in the passage, right? There's something wrong with that. Maybe you've got a pelvis that's just oddly shaped. There's a couple of them, right? The passage, maybe the baby's coming down asynclitic. Or maybe the baby's not really wanting to engage, or maybe the face is coming down first, or the head's not totally flexed. And then the biggest one, I think, that can really affect people is the psyche of the mom. Right? If she's not really doing well, and she's totally worried about her birth or something else, she can affect her birth as well. Okay? The term dystocia is really just difficult labor. Okay? Right? It just means that it's not going well. All right, let's talk about these uterine contractions. In the first stage, They're the primary force, right? But they're a little bit a different kind of force. Second stage, it gets a little bit different as well. But in the first stage of contractions, right, you're going to have a lot of back pain first, so it'll travel through your back. So remember when we did all those grunting sounds, right? When you did that to get this baby out, that's second stage. This one is really more around where the uterus, actually how it works, and Audrey explained a little bit last week too. You've got two sets of uterine fibers, muscle fibers. The lower third is your lower uterine segment. That's gonna be your fibers that are gonna turn that baby. If a mom's just sitting in bed and she's got an epidural, it's going to be really hard for that baby to move. We're going to have to switch her positions in order for that to happen. But the top 2/3 are her expulsive efforts of the uterus. So if you have a contraction that's just sort of piddly, okay, it's not very long, it might travel through the back, but once it reaches the fundus of the uterus, the tip of the uterus, it has no propulsion efforts, okay, right? Because those are the long 2/3 of the uterus, the long uterine fibers that push the baby out, rotate the baby, okay? All right. In the pushing phase, you might have a couple different things. Maybe you don't have forceful enough contractions. Or maybe you have a mom that's pushing all in her face, right? So when you start grunting and showing her how to grunt her baby out, she's going to get those contractions moving, all right? So let's talk a little bit about some of these. All right, so there's a couple different things you have to think about. We're going to talk about when is it failure to progress in labor and when is it failure to descend. Now, in just the 2 words, you can figure this out. If you're not progressing, it's usually because of uterine contractions. So in that category, when you're doing your studying, put failure to progress and the 2 types of contractions in those that category. Hypotonic contractions and hyper. Okay? Too little and not strong enough, and too many and not strong enough. Okay? Hyper, hypo. Or you might have ineffective pushing or a failure to the baby's descending. Okay? Now, let's talk about that. If a woman has done all these contractions and the uterus has done all that it's supposed to do and she's fully dilated and the baby's sitting right at the engagement, right? But it gets stuck there, which happens, okay? That's failure to descend, okay? But if she's stuck at about 4 or 5 centimeters and she's got effective contractions and you've been monitoring for her for a couple hours, right? And she's not dilating anymore, what is that? Who can tell me? Failure to progress. Okay. All right. And then another thing that can happen is precipitous labor. I was considered by my 4th baby somebody who had precipitous labor. Okay. I told people, don't leave the room. When I say my baby's coming, I'm serious about this. Okay. Ben has been able to catch 2 of the 4 babies, literally. Okay. Because people left. All right, so you have to believe the mom. If mom says baby's coming, or I'm a fast laborer, especially when my water breaks, okay, before that, not so much, which is very consistent with research, you know that you have to listen to them, okay? My baby's coming, you have to listen, all right? They know, especially if you're unmedicated. There is no way you're holding that baby back, okay? Precipitous labor, though, is really something that happens so quickly that most people think, and it's not very often that it happens, that you have issues with drugs, okay? Or you've been doing something. So even me, who I don't look like I might do that, but you know, it doesn't discriminate, I would be labeled as someone that would need to be followed up or at least asked a few questions, and sometimes even the baby's bagged after this if I have a precipitous labor. It's protective, okay? Women who do cocaine or do multiple days of drugs, whatever that is, you know, heroin, whatever, they have labor that is very fast. They come in and it's very fast. Placenta comes with them. It's very quick. Okay? So we do have to monitor these people very closely. When you have ineffective uterine contractions, they are so frustrating. Okay? You get very tired. You feel like you can't do much. It lasts a long time. You might even not drink well. Okay? You can become hypoglycemic because you're not eating and drinking well. You might need a lot of pain medicine because you're just annoyed by this. These are the people that come in and out of your labor and delivery units and can be what we call frequent flyers sometimes. Okay, and it's very frustrating for me to even hear that term when that happens because these are the types of people that need a lot of support. Okay, these are the type of people that you hear them say, you know what, my labor was 3 days, and What you're trying to say, you know that it's just prodromal labor that just won't kick into active labor. Okay? The harder thing here is when you have this kind of stress, you also secrete catecholamines and cortisol, which does not allow good labor. So you have a lot of mechanisms that are happening. Okay? It could be because you've got that CPD, cephalopelvic disproportion. You've got a platypoid pelvis, and you've got a large baby. And that baby just can't get through. And so the contractions, the baby's head cannot apply to the cervix well enough to get enough of these good contractions to get that cervix to dilate. Okay? Or you might have just uterine distension, polyhydramnios, multiple gestations, something else that's causing this ineffective uterine contraction. All right? So that's when you think about hypotonic contractions first. Okay? These are the ones that are coordinated. So you might see good timing of contractions, but they're weak. All right? They become less frequent, and they're very short in duration. Sometimes they're even indented in the peak, meaning that the fundus is not getting an opportunity to contract. Okay? It might be that they have minimal discomfort, okay, because they're very, very weak. So when you think about hypotonic contractions, you're going to think less pain, okay? Why? Because they're just kind of piddly, not that often, but very annoying. They're tiring, and they do get very, very fatigued, okay? When does it usually happen? In active labor, okay, after 6 centimeters. Why does that happen? It could be a couple different mechanisms that happen, kind of what I talked about, okay, right? And so we use 6 centimeters. I updated my slides to make sure that you know this, okay? 6 centimeters is usually 5 to 6 is going to be your active labor, okay? Some institutions will say 4. So in case you hear that, I just want you to know that. But for our purposes of today, we're going to talk about it in 5 to 6 centimeters for active labor, okay? All right. Okay, what do you do? What can you do for these people? Well, you can rupture the bag of water and see if that head can get down better onto that cervix and cause more contractions. Okay? You can give them oxytocin. You can augment their labor. But sometimes this is, if you try everything, you rupture the bag of water, you do change of position, maybe even offer some pain medicine, and you give oxytocin, some of these women do not progress. What would they be called? They're not dilating. What's the term? Failure to progress. Okay, good. Good. So there's a couple different things. You, as a nurse, you're not going to be doing the bag of water rupture. Okay, you're not going to be doing that. Your nurse midwife or your physician will come in and do that. You can do a couple different things, though, to help them, to support them, let them know what's going to happen, get the lining of the bed well done, those kinds of things. But the position change is going to be huge. So a woman that is so uncomfortable and doesn't want pain medicine, and then we start all of this, an amniotomy, and we give oxytocin, whoo! Okay? So I used to say, to myself, to hold off as long as I can to get my bag of water ruptured. Okay? So having 4 babies, sometimes my bag of water ruptured on its own too early, and sometimes it had to be ruptured. On Gracie, my last one, it had to be ruptured. Why? Because we waited and waited and waited for the group beta strep. Okay? I waited 4 hours, got my dose of antibiotics, ruptured the bag of water, so I was about 4 to 5 at that point, and Gracie came 2 hours later. And it's very fast labor, okay? So we're going to be really supportive of that, because what happens is I was a very sweet, kind, loving person before that happened. And after that, not so much, okay? I'm sure you guys can't even imagine that. Yes, so anyway, so what happens is when you do that, so then you go from being, oh, wow, I know this person pretty well, to, wow, I really don't. And so when you learn and see people that are in labor like this, it can be very shocking. And most of us, thank goodness, don't remember how we behave in labor. So we'll say, like, if you ask our birth story, we'll just say that, oh, it wasn't so bad. It was fine. And so our partners usually will say, yeah, I don't remember it that way. Okay? Right? So, but that's okay, because it's protective. That's why we go on to have more babies. Right? That's why we go on to have more babies. Okay, so the emotional support is big on these people, mainly because sometimes that doesn't work, right? They go in through all this pain, okay? I do all these things. So that really was my second born baby, Owen. I had so many things I was doing. I had delivered 4 babies that weekend on my own as a nurse midwife on call. My bag of water ruptured a little bit early. It was a high leak. I needed to have a 4-bag ruptured. I was stalled. I tried everything. The birthing ball, the rocking chair, anything anybody told me to do, and I could not get past 5 to 6 centimeters on him. I had to, at that point, take an epidural and get some relaxation, and still it took a little bit of time, okay? Now, it's called somebody that's, I wasn't ready for labor, okay? So sometimes that can happen. I needed a lot of emotional support for that.
That you want, that they say, all right, let's go do a C-section.
Okay, good. We have criteria, okay? There are a couple different protocols. There's an induction protocol, okay, and a normal labor protocol, and we give certain numbers of hours, and it's an algorithm that most of your hospitals follow, okay? For the second stage, when we start talking about pushing, protocol that's still at most hospitals is actually the one that I created through my DMP project, okay? So if you ever want to go into the chart at some of your sites, I don't know if all the Mayo system has them. A couple of places do, but you would see that one. I'll show you. It's just an algorithm, and it tells you how much time people can be in before we actually make decisions like that. Okay? So we allow them all sorts of opportunity. We don't just say, oh, yeah, you know what? It's 5 o'clock. Which sometimes happens, right? In some parts of this country, people are done for the day, and then they'll think about C-sections on people. Okay, we have to give them, now there's protocols. We give them time, and we make sure they're ruptured. We make sure oxytocin's been given to them, and that pain medicine's been offered. Okay, now for me, I had been ruptured since about 6 in the morning for Owen, my second baby. He didn't deliver till 11:30 that night. So I was in a long period of time. Okay, right, and I was not getting a C-section. I'd rather take an epidural because I wasn't really into epidurals at that time, but I took it because I knew that that was the best thing for me. Okay. I delivered pretty quickly after that. Mine was a cortisol, mothering, overwhelmed, no sleep issue, that baby. Because I had been gone since Friday morning, and I had a 3.5-year-old at home, Aiden, and so I had lots to do at home, and I wasn't ready for this baby, right? I thought, wait, I at least have another week, right? So that was my brain chemistry for that. So that's why that labor didn't work that well. And that's that psyche. Can really affect you. And I willed it. I'm going to do this, but I couldn't get it to do it. Okay? So sometimes you got to reduce that anxiety, or you got to take pain medicine. You got to do whatever you have to do. The thing that I always think about as a nurse midwife, when I was still doing deliveries, is when you think about working with women who have, who are wanting to have a baby their way, without pain medicine or whatever, you name it, whatever way a person who's, intending to parent, right, wants to do this and parent well, you've got to think about having a baby in the quickest time possible and sort of allowing for other options. And sometimes we don't do that, and that can really affect us in our labor patterns. Okay? That's that psyche. So, all right, let's look at time. My hope was to give a break at 9:30. Is that good for everybody? Can everybody go for about another 20 minutes? How about in the Twin Cities?
Yes. Yeah.
You guys good? Is that a yes from you guys?
Yes.
Good. All right. So amniotomies. This is what the amni hook looks like. It looks like a little crochet hook. It is very sharp. So as somebody that was responsible for rupturing bags, I had to be real careful. I would start my vaginal exam and actually just slide it in between my fingers and protect that tip so that it didn't catch anywhere inside the vagina. And then I would release it out of my hands without hurting opening up any sort of part of my glove. And with a contraction, you'll get a bulging bag with a contraction. When that happens, you wait for the contraction, which is not fun for the mom, right? Because, of course, she's getting a vaginal exam during a very uncomfortable time. And you take the bag of water, you just pull it down, and you rupture it without cutting the baby's head. Okay? And it's a very, very slow process that you let the water out. So once that's opened up, my hand stays in there, and I very gently, because usually if there's a big, large bag of water, there's a lot of gush, so I'm protecting myself, and I'm bringing that head down very, very slowly. Now, a baby that has a bag of water ruptured you're going to see some dips in the heart rate. That's very, like, all of a sudden, right, they're floating, and then you've got this thing, okay, that happens, and it's the milieu changes, and the pressure changes, and that baby's heart rate will change. It's kind of like a vasovagal response, that 10th cranial nerve. Anytime that nerve is ignited, babies, anybody, us too, our heart rate will go down first. And it'll take about 2 to 4 contractions for the baby to settle into the pelvis, okay? Right? So that's what we do. It's a very slow process over a couple contractions. Okay, moving into hypertonic contractions. Okay? These are the ones that are uncoordinated and irregular. There are a lot of them. They're short, but they have hardly any intensity. But here's the deal. They're painful. Okay? So when you think about hyper versus hypo, one's painful and one's not so much. Okay? But they might be minimal, and so they might not complain as much. All right? The thing about the resting tone, so we talked a little bit about this in Care Families 1, and I'm sure you looked at this. The resting tone is the milieu of the inside of the uterus, measured in millimeters of mercury, with pressure, okay? And the pressure is given to that bag, that water that's surrounding the baby in contraction pattern, okay, in the contraction pattern. Now, when the uterus relaxes, it relaxes to about 10 millimeters of mercury. Anything higher in that 20 or more, we have some grace for 20. But when we're monitoring this internally and it's above 20, what can people think about what's happening? What happens if a tone is too high? What do you think is happening? What's the uterus doing?
Not relaxing.
Yes. Great. It's not relaxing in between contractions, right? There's an issue going on, that uterus. That's why we only give a little bit of Pitocin, because we want that uterus to relax and then, do what it needs to do. But if there's too much tone inside the uterus, that's a cause for concern for both the baby and for the uterus. We're thinking some other things are going on. Maybe the blood pressure's too high, okay? Right? Some other things are going on. All right. Usually this happens before that 6 centimeters, before, okay? Right? With hypotonic, it's after. Okay? However, these are a little less common than your hypotonic contractions, all right? So what do you do for these? You got to identify the cause. Why are we having too many contractions? Now, in some systems where the body is trying to get practicing to do contractions, sometimes if you do a little bit more Pitocin, if the patient's on Pitocin, you push a little bit more, give a little bit of a bump up, it'll push a couple of those contractions together and make the coordination a little bit better, okay? When you have a short contraction, remember what I said before, a short contraction does not change a cervix. You need a good long 60 to 90 second contraction, okay? So sometimes we might be just in these hypotonic contractions because our contractions are not long enough, right? So we have to do a few things. And I used to really understand, not used to, but I used to practice this when I worked on the labor and delivery unit in a couple different areas, as a nurse midwife, as a nurse, and then also as an advanced practice nurse leader, where I would train nurses the art of oxytocin management. And there is an art to it, okay? And getting that contraction pattern nice and pretty. Okay, when to bump it up, when to slow it down, right? When to watch it. All right. It's good to put this woman on her left side or in a comfortable position, okay, and help her get through this. Sometimes if you get too much tone over a period of time, you can give a tocolytic. Do you guys remember what the tocolytic? There's a couple of them that I mentioned, but it starts with a T that we can give if we got too much tone just a couple different times. Terbutaline, good. Right? We only give it a few bumps because it causes increase in heart rate of the mom and in the baby. So we can relax that uterus and see what's going on. Okay, again, this is another one where these can be really painful and they can cause a lot of anxiety because she's wanting to get into good labor. All right, my favorite part, ineffective pushing. All right, let's just do a recap, and I'm going to really want to hear it loud, especially for Dr. Meacham, because she knows about this. In the Twin Cities, let's do a recap of what it feels like to push well, okay? Because then you're going to really understand what I mean, okay? So let's remember, we're all gonna take a nice deep cleansing breath. I want everybody to do it, and if you don't do it, I'm gonna make you stand. Do it with me, okay? Even everybody, okay? So you take a deep breath. Everybody take a deep breath. Twin Cities as well. Take a deep breath and let it out. All right, yeah, I hear it in there. Take another deep breath. All right. Now I'm gonna have you hold your breath. Hold your breath and push your baby out. Hold your breath. I want no sound. Okay? Hard. Push your baby out. 1, 2. Come on, hard. Push it out. I want to see it. No sound. 3, 4. Oh my gosh. Come on, you guys. I need you to get to 10. All right? Try this again. Okay, let's do it. Take a deep breath. Everybody. What? What do you say? Oh yeah, absolutely. We want the guys in here when everybody's leaving. Guess what? We're in the labor and living room. They're going to be doing this, right? This is what nurses tell you to do. This is what's still on the labor and delivery units. We're going to change it up here, okay? All right? I want everybody to take a deep breath. Let it out. You're going to hear me do this, right? Take a deep breath. And I want you to go like this. No, now you're going to without me talking. And I want all the Twin Cities. I see you guys now. Everybody take a deep breath. Even Mike in the booth. Everybody. Take a deep breath. Rylan too. Take a deep breath. Let it out. Now take another deep breath. And grunt. There we go. Mike, I heard you. Okay? Everybody's grunting. Why are we grunting? Where do you feel the pressure when you grunt? Where do you feel it? Right in your bottom. Why? Because you can't grunt without feeling it. Okay? If you hold your breath and you have this happening to you, 2 to 3 hours of just pushing, holding your breath, that baby doesn't come. And it really doesn't come. But if you watch any of these like shows like Call a Midwife or whatever, and you have people crying or calling their babies out, as they say, grunting their babies out, okay? Some people like kind of yodel and do different things. Anything to get their baby out. I used to scream, "Oh Lord, help me," as I was pushing, okay? Well, it was so embarrassing that I was so loud, because I'm still not so loud, that I would walk out of most of my birthing rooms thinking, oh my gosh, I just know people are going to be staring at me, okay? But the better that you yell your babies out, grunt your babies out, the faster they come. Now, on most labor and delivery units, they say, no, hold your breath. We like it quiet. We like epiduralized, quiet people. We're used to that. We're getting more and more loud people. So I want you guys to pay attention. How many of you have done a birth? Let's go into that real quick. How many of you had a birth so far? Great. Do you want to share?
Anybody here?
Was it unmedicated or medicated?
Supposed to be unmedicated, ended up medicated.
Okay. Oh gosh. Okay. Did you get to see any pushing?
A little bit, but not much. I didn't keep dilating.
Ah, okay.
And we had my tummy out for like
Okay.
8+ hours.
Okay. Okay. So you had a lot of different things going on. And you have anxiety because of meconium, all that. How far did she get dilated?
I think 5 or 6.
So she was not in good labor. She never got into. Oh, that was you. Oh, okay. I was just wondering about labor and delivery, local. That was yours.
Yeah.
Your baby. Okay. Okay. So lots of things going on for you.
Yeah. They did pitocin and took me off of it, and then took in the epidural because every time I contracted, his heart rate went down in the 3rd floor.
Okay. At the end, did they notice where the cord was? Was the cord around the neck or anywhere near?
They didn't tell me, but
Okay.
no.
Okay.
They kept looking though, and they kept looking for the fluid. My water broke at like midnight, and I finally did C-section at like 7:38 the next morning.
Okay. So you had a lot of these things that we were talking about. A lot of that. A lot of different ways. So that's perfect case. Perfect case. And then some medicine as well. But really, we know now that when you're not actually at 5 or 6 centimeters, you're not really in actual labor yet. So it's a cause just to rest. But you had a ruptured bag, and we had to do something. Okay. Anybody local here that has been in labor and delivery that had a birth so far? Yes, go ahead.
Well, the birth that I witnessed, actually ended up being a C-section just because she had some ineffective pushing, and she pushed for 2.5 hours, and the baby wasn't as far as they would like it, and she was just very exhausted. Like she wasn't expecting to go into labor, so she had like an overnight shift the night before. So she had been up for like 27 hours.
Yep.
So she was getting like very fatigued, and she also was like holding her breath a lot when she was pushing, which also kind of fatigued her, I think, too.
Yeah.
But they did tell her like to relax when she was pushing. That like she kept like
pushing in her face.
Pushing in her face, yeah. So they kept telling her to relax, like everything except for down there. But I think she also had an epidural, so she also had a hard time with
feeling
and like and kind of like focusing that pushing on the right spot.
Yes.
So yeah, she ended up going into C-section.
That's tough. Real tough.
Do you have a coach in the room at that time? Like someone?
You know, some people have doulas present, and you know, their partners have gone through hopefully some labor coaching, but it's hard. It's really hard when you've got somebody that's got all that going on and is exhausted. Nobody prepares you for the labor that you're going to have, and it's often referred to as a marathon. So it's 3.5 hours plus pushing sometimes for people. We allow them to do that. They just aren't in good enough shape to do it. And when you push in your face, some people actually have broken blood vessels in their face, petechiae, from pushing in their face. That's why when you grunt, it relaxes up. Can you tighten up your face when you grunt? No. You're everything's right in here. It's relaxed. Your shoulders are relaxed and everything. You know, it's called open glottis pushing. It's well documented. Nobody should hold their breath for longer than 6 seconds because it cuts off the oxygen to the baby, right? The pH goes down naturally. Lots of different ways, but trying to get people to change it is hard. It always makes me sad to hear people have had cesarean sections. How about the Twin Cities? Anybody had a birth?
It doesn't look like it. I see a lot of heads shaking no.
Okay.
Anybody have witnessed a birth? Nope,
Not yet.
not yet.
Okay. Check in next week. All right. So for 4 minutes, all right? So again, thinking about all the things that go in. So it's pretty amazing when people actually have a vaginal birth, right? You think about all the mechanisms, right? And then you have some people that come in, they barely say a word. Their contractions are fast. They're coping well. They, push for 40 minutes, and out comes a baby, right? So those are the ones that kind of trip you up when you have these people that cannot get into good labor. And a really good nurse midwife and a nurse and a provider is going to try to figure out what's going on internally, okay? Luckily for me, I'll just use Owen as an example. I was able to actually verbalize how upset I was that I was in labor. I was so upset. I wasn't prepared. I felt so inadequate at that time. I hadn't seen my 3.5-year-old. At that point, I was going through what a lot of women go through that are having their second babies, where they're wondering, can I even love another baby as much as I love my first one? I had just all these different things. Ben was completely checked out at that point. He was supposed to go away for that week. That was his last week of travel. He had to postpone that, had all these things that he had to get done. So while I was laboring, he was on his computer. It was all just not how I wanted it to be. And this is one of the funniest videos that we have. Ben likes to videotape, okay? But always in the back, so it's this way, right? Keep everything PC. And I had that not known that I didn't like to know what the sex of the baby was, okay? And so the gender of the baby. And so what happened was, as the baby was coming out finally, there's this video of Ben going back and forth. He doesn't realize he's being taped, but like this. Push, honey. That's what and it was hilarious. And then the baby comes out, and I'm pulling my baby up, and I'm like, it's a boy? Like that, I was shocked. I had, in everything that I knew about this next birth, I dreamt girl, thought girl. It was totally different. I had no idea. And Owen teases us, because every time he says, he's like, yeah, right? It all started in the beginning. You guys all wanted a girl, type of thing. But no, we were like, and then of course we picked it all up, right? And we're like, oh, it's a girl. Yeah, or it's a boy, right? So it was so funny to have this video and watch this video. And it just was a conglomeration of just many different things. And I was just thankful that I even got through. and was able to have a vaginal birth on this one. But you could see all these different things going on, okay? And I had all the different mechanisms, okay? All the mechanisms present that should not have allowed for one of those types of births that should happen pretty within the hours of time that are allotted, okay? I had protracted birth, okay? A protracted birth. All right. So let's finish these last few slides. When you think about ineffective pushing, you can try a bunch of different things. First, I would try to get them to grunt their baby out, okay? All right? If you have too much of an epidural, you can allow for that to be backed down a little bit. Turn it off, not all the way, but start to turn it down, okay? Now, if you have a baby that's stuck and it is at +2, the baby's at +2 or greater. Remember, when you think about the ischial spines, +1, +2, +3, +4, crowning, +5 out. If the baby is at +2 or below, I can place a vacuum or put a forceps on to help that baby come, okay? Now, when you do that, it's very, very difficult on the mom and on the baby. Sometimes you have to cut an episiotomy, very uncomfortable. But if it's because you're thinking baby's heart rate's down or mom's just ineffectively pushing, you can help that along. That's one thing you can do. Okay? Or you'll have to move to cesarean section. All right? But things that we can do as nurses, we can help them push by doing some different positions. Squatting is a great way, using the birthing bars that you can do. People can lift one leg up. If they're open to having different positions, push on their hands and knees. Where the wider the pelvis, the better, okay? So pushing and some people can push on the toilet, right? Because they're used to that type of movement. So they can push on the toilet. Trying anything you can. If you've got an epidural that's dense, you only have a few options, right? And you don't want to hold the leg yourself, okay? You want to have somebody else hold the legs with you because those are really, really heavy, okay? So trying multiple different things to get people to push. These are some pictures of people doing this. Now, that's the birthing bar. People hanging over that, kind of squatting. Gives some relief for the nurses too. In that same position, you can also use a towel or a rebozo and push and pull with that mom so she pulls with you. It's exhausting for the nurse, but it works really well to bring the baby down and at least to focus the attention of where the baby should come. You can use a mirror. Some women are very open. When they start pushing, they can see the head coming, okay? And that's really motivating to them. Okay, so remember that the curve of Kiris, where the baby's navigating underneath the pelvic bone, there's a rocking sensation that happens. This is a very difficult, tight area, so it doesn't happen quick. So as nurses, any little progression is good progression, okay? So sometimes those babies come out a little bit molded, but they handle it very, very well. It's amazing, okay? All right, 9:30, this is a good time to just take a break. Okay, let's take a good 15-minute break. I want everybody to get up and stretch. All right, get your coffee or whatever you need, and we'll be back.
Cold probably doesn't help.
No. Yeah. Are you just gonna take
I feel like wasn't her sister. No, it was my dad's brother's wife. I was like,
I'll meet you back up.
For me, I don't have to now.
How are you? Good to see you in person.
Yes, I know. Finally, you're
Yeah, I know. All right. We're going to get started.
We're starting again, folks, so let's check.
All right. I already a lot.
We're having trouble hearing, Sam. Talk up, please.
We ready?
Yes.
Okay. So I've already gone through precipitous labor quite a bit. The only thing I want you to pay close attention to on this slide is just that it's less than 3 hours usually, start to finish. Okay. That's why you have to think about a couple different things, right? You got to think about possibly there's some other comorbidities that are going on. You want to think about postpartum hemorrhage, right? That uterus all of a sudden was working very, very hard, very, very quickly. It might forget how to clamp down. Okay. The baby then also is going to be pretty traumatized, coming through the birth canal pretty quickly. So you might get an abnormal fetal heart rate tracing. Okay. The baby could be hypoxic from all of it as well. Okay. Too many contractions can cause the baby not to be able to catch its breath, literally. Okay. So you want a good amount of relaxation time in between contractions, about 60 seconds at least, so that baby can breathe. Okay, and then these are the types of babies that come out, when they come out so fast, they'll be really bruised. So they could have some cerebral trauma. Okay? Sometimes they'll get a pneumothorax from it. And oftentimes, this is your most often type of person, baby that might get a broken clavicle coming down too fast. Okay? And it's not any, any problem with how the birth technique happened, but just it comes very, very quickly. All that makes sense? All right, so now we're going to go working into the passage, ways that the baby might not fit, okay? Right? And it's the descent of both things, baby, right, coming down, and then the pelvis and the introitus being able to actually do the work it needs to do. All right, the big thing here is cephalopelvic disproportion, just as the word talks about. Cephalo meaning the head, pelvic meaning the pelvis. Those two together are disproportionate, and they're not able to compensate for this. Okay. Sometimes it happens with large babies, although some women have no problems with large babies. Okay? So I often just kind of preface that. Okay? The biggest issue we see here, though, is a baby that's possibly too large and a pelvis that's too small, where a baby just will not engage past the zero station, just will not make it down, or it'll stay ballotable. So if you remember where the ischial spines and how this all works, the ischial spine zero station where we sit, right? You can actually feel that. That's where the baby engages. That's the most narrow point of the pelvis, okay? But a baby before that, it's ballotable. So if I did a vaginal check, I could push the baby's head and it would come up and down, up and down. That's that term ballotable, okay? But then there's some babies that are just not even to the point where when I do a vaginal exam, I can't even feel their head. I can't feel a shoulder. I can't feel anything. Those are babies that are floating. They're just refusing to come down. Those are the ones that have a lot of amniotic fluid. Those are the polyhydramnios. They just don't come down, okay? Now, a way to get that baby to come down a little bit quicker is to rupture the bag of water, okay? And do it very, very slowly. Like I said, let the water come out real slow. All right. So this is just a picture just showing that there can be, when you think about your hand in relationship to the head, there can be this kind of inability to feel the head, okay? And that baby just can't make it down there. And that's a pretty good, accurate picture in terms of how big the head looks in terms of the introitus to the, inside the cervix and everything like that. So you can tell how small of a passageway this baby has to navigate. So the contractions have to be very forceful to get this baby down, especially when you're working against literally like a balloon, right? The bag of water. Okay? Right? And this is a baby that was 10 pounds, 7 ounces. So it's a large baby, so it's going to have a harder time to get down. There have been babies that are born vaginally, 11 pounds, 11.9, 12.2. I've seen them, delivered some of them. And yeah, they take a long time, but moms are able to do that. So what you're going to want to do is you're going to figure out what the size of the baby is. And that's usually done by Leopold's maneuver. So go back into your thinking and some of your reading, right, from Care Families 1. Leopold's is when you actually lay hands on the belly, and as a labor and delivery nurse, you will be trained on EFW and making an estimated size of the baby, okay? Your nurse midwife and your provider will also do that, all right? So you've got a large for gestational age baby, you're going to have a little bit longer labor possibly, and anticipating that, okay? The key is there are these different algorithms, and even these types of babies that are large still need to fall within these categories on the upper end of it, right, on this labor algorithm. We're not going to let them fall too outside of that, right? So we're going to make sure they have progress in that first stage and in the second stage of making their way through the pelvis, okay? And we're going to adjust if we have any issues in between. When you think about that Leopold's maneuver, you're going to be looking at the lie of the baby, how is it? Is it asynclitic? Is it transverse? What is it doing? The attitude of the baby, how is it facing? Is the presentation, is it head? Is it bottom, right? This is a breech baby. And the position, is it looking to the right? Is it looking to the left? So right occipital anterior, right occipital posterior, or left, okay? Okay, so what we're looking at, all those different things. And you can assess that by doing Leopold. Okay, you can tell where the back is. You can tell if you're feeling fetal parts. You can tell where the head is. Okay? If you ever have a question when you go into a vaginal exam, usually that's when people think, oh, am I feeling a head or am I feeling a bottom? Sometimes they'll do a vaginal check and they can feel a nose, okay, or an ear, okay? So they'll say to themselves, I need to do an ultrasound to confirm, okay? All right, so fetal size can be a complication, their presentation, how they're looking, or if there's a couple babies in there, okay? So we'll make sure that we cover all of those. The biggest issue with cephalopelvic disproportion is macrosomia or a large baby. So greater than 4,000 grams, okay? And especially 4,500 at term. Okay, this is a baby that is could have the complication of diabetes. Those babies grow a little bit faster, right? And they collect their fat in odd places. And the oddest that they collect it at is around their neck and shoulders. And these are the babies that are the highest risk for shoulder dystocia. Okay? Right? The biggest thing that we watch for on this complication of birth is called the turtle sign, where the head comes out and then it ricochets back. So most of the time when a head comes out and there's no turtle sign, the head will just stay there, and I will say to the woman, pant, take a deep breath, and on the next push, I'm going to have you very slowly give me another push, okay? On this type of baby, the head comes out, and it literally does this. It comes out, and then it pulls back in, just like a turtle. It's your number one sign, and it is conclusive. It is conclusive. As soon as I see a turtle, I call it out. I say, I have a turtle sign. Anticipate a shoulder dystocia. I say it out loud. I get another nurse right away. I have a stool at the bed. I get another person up on that stool. Okay? If I'm the nurse midwife, I start directing them in some very, very clear direction. I have about 2 minutes to get the baby out. This is that case where this is very serious. This is one of our most common obstetric emergencies. Okay? Right, that we have, even though they don't happen very often. It's one that we do see pretty often. And we train on it, we do simulations on the floor. Nurses do it and providers together. Okay, so again, the turtle sign happens. The baby ricochets. If I'm the nurse midwife, I will say, I see a turtle sign. I need you to get an extra RN. Call the NICU team. Okay. As soon as that happens, most of the nurses, if you're short, you're already going to have a stool ready by the bedside. Okay? Why is that? Because sometimes you need a little bit of extra leverage, and especially if your provider likes to deliver with the head up higher, okay, or the bed higher. Okay? I'm short, right? So I had my bed a little bit shorter. But most people would either way grab a stool. Why is that? Because what happens, they get on top of the stool as soon as I assess where the shoulders are. So with a baby that is a turtle sign, they come out, right, and they ricochet. Most babies come out and they start to restitute, right? If you think about a gynecoid pelvis, right, like this, an oval-shaped pelvis, when they restitute, they go to the oblique angle. The oblique is the largest angle of a pelvis. Okay, so when they come out, right, this is like they only have so much room. They're smart enough to go and restitute out or around. As soon as I feel that, I'll see which way they're going. So sometimes babies are confused and they'll be looking this way, but trying to turn this way. Now, I can cause a paralysis here if I don't know which way they're looking. So I go in, and my hands go in, and I do a sweep. I'm sweeping for a couple different things. I'm looking for the shoulders, and I'm looking for a cord. Okay? I go in, I tell my RN, I say, okay, what I'm going to have you do, it looks like the shoulders are facing the window. I'm going to turn the baby, and I want you to give me suprapubic pressure towards the window. That's why you're on a stool, and you'll push down on the shoulder. What you're trying to do is help me get the shoulder underneath the pelvic bone. Okay? When that happens, that is a big deal, right? So I will try it a couple different ways. I'll try to restitute one way, and I'll try to actually restitute the other way sometimes. If I don't get any movement, then I have people do a couple different things. One, I'm going to make sure that everybody's present in the room, and I'm going to do Mick Roberts' position, which is getting the legs as wide as they possibly can. Okay, so we're going to get a couple extra people. Most of the time, by this time, the partner that's in the room, or possibly the mother-in-law, everybody's pretty shocked and they're out of the way, but we want to get at least somebody helping us with the legs. And we'll tell them, pull the legs back. Okay, pull the legs back. Okay, so what we'll do is talking all out, and I'll be calling it out. There's always going to be an RN in the room that's calling out time. Okay, they might say, Dr. Summerness, we're at 30 seconds, or I might say to them, within every 30 seconds, let me know where I'm at. It's the longest amount of time you've ever believed you're at, because it's a panic mode usually, and you're calling out different things. Most of the time, we can get the baby out as long as we pull one shoulder out. We can actually pull one arm out. Once I get one arm out, I can get the next arm. Okay? If none of that works, right, and I can say, get my backup in, get another person in there, okay? If another person comes in, sometimes I've been called into a room and I'm a fresh set of eyes, and I'll come in and put my gloves on, and and I'll do my maneuvers, and the baby will come out like that. I've had that happen before, where you're the provider in the room and you just can't see the forest through the trees. Okay, so it's okay to get another person in to get your help. Okay. The other thing that we might do is making sure that we do no fundal pressure, right? We don't want to go too low. What we're trying to do is just do directed suprapubic pressure, like I said, to the right, to the window, whatever you need to say to them. Okay, trying a bunch of different things. There's a couple different things that can happen. Clavicle can be broken. Okay, you can actually break the clavicle. Okay. You can get that shoulder out. Sometimes you'll have a little bit of a problem with the shoulder afterwards, but the baby's going to be alive, so that's going to be okay. So that's happened before. But the other thing that can be really bad is if you can't get either, all right, you only have a couple minutes, you can do something called Zavanelli, and that's pushing the head back up and going to a cesarean section. I've only seen it a few times, but it's a very stressful case, and then you rush back to do a C-section. Those babies are usually, for sure, in secondary apnea by that time and will require a full resuscitation. Right? What happens, we talked about this last week, what happens when the baby hits the air outside of the uterus, right? What happens? It starts to breathe. It's a normal response. If you get a baby that's in primary apnea and it's doing that for the first minute, usually it's respiratory, we can fix it. But anytime you go into that secondary apnea, after 2 minutes, you've got some other metabolic issues, right? That gets to the tissues. You've got a bunch of different things that have to happen. If you go longer than that, we have some things we have to take care of. We have to maybe cool the baby and put this baby on some protocols, okay? So it doesn't happen that often, but it has happened enough for me, and you might even see it. We had a few nurses that saw it last semester, okay? So, and it was stressful, but everything we said happened. So do you see where when I say suprapubic pressure, it's directed suprapubic pressure, okay? Just helping that shoulder get underneath the pelvic bone. Okay? Make sense? Okay, so then we talk about rotation abnormalities. There's a couple different things that might happen. Okay, you have deflection, or you might have a breech issue where there's no rotation happening. It's very hard for a baby to do any rotations that it needs to do in the breech position. Okay, right? The biggest one that I want to talk about is OP. This is when the baby's looking up when they deliver, sunny side up. Largest diameter of the head is coming through at about 13 centimeters. Normal is 8.5. Okay? Unfortunately, it does occur enough in about 25% of birth. So we have to be prepared for it. On the second stage guideline that I helped create, we actually, if we knew that this baby was OP, we would not push them, and we would do some rotation. We would do it in the bed and start rotating, getting her on hands and knees to get the baby out of that position so it did not come through the pelvis fully like that. Once the baby's engaged, it's hard to turn this baby. Okay, it's like going down a slide in a sleeping bag, zipped up backwards. That makes sense? That's how the baby's trying to navigate the pelvis. They don't know where they're going. They don't know and their biggest thought is extend, right? Even further extend, right? Which will be bigger diameter. Now, when they go down the pelvis and they're looking down and they're nice and flexed, only this part of the head, right, is coming down the birth canal. So when they present and they restitute, it's the smallest portion of the head. But when they're OP looking up and going down through the pelvis, they have no way to navigate. These are longer labors. They also can create third and fourth degree lacerations. You could have a vacuum. You could do forceps. And some of them go to C-section. Okay? Any questions on those? All right. What do? We do a bunch of different things. Just turning them, like I said. You can do some sacral pressure to get that baby uncomfortable. Get that head, the butt of the baby, the butt of the mom, right, up high, because the baby gets really uncomfortable in that position if she's able to do that. You can do lunges, squats. The key is get the baby uncomfortable. Get the baby out of its normal position, get it to move. And sometimes this really works. Hands and knees is your best option. It's the largest diameter, and most babies want to turn when they're in that position because now they've gone from looking up, right, and they're looking down, and it feels kind of funky. All right, so we're going to get them to rotate. Make sense? The key is to get this done before you get them engaged. So if there's one thing to remember that. Okay? All right, and any lunge, anywhere you're lifting or getting that pelvis in the largest diameter, you're going to get that baby uncomfortable enough to do something. Of course, this doesn't work that well if you've got an epidural. Okay? So you got to be turning them in the bed and doing different things in the bed. Anybody seen peanut balls yet on the labor unit? Twin Cities peanut ball yet? Okay, I want you to look for that. Huh? Yeah, it looks like a huge peanut. Okay, peanut balls are used for babies that are in the OP position. The mom, it literally goes in the bed and their legs go around it and it opens it up. Okay, it opens it up to the widest diameter. So I want you to look for those on the unit this next week, okay, because everybody's got them. Okay? All right, these are the issues with deflection. Flexion is right, the chin is nice and down. Flexion, deflection is when it's open. Right, okay? Right, so that first picture is complete flexion, right? You can see that small itty bitty portion of the baby's head coming down. Does that make sense? That's a great picture, all right? And you can see where the fontanelles are. They're pretty easy to find, right? The baby's in a great position. It's got enough room to come through the pelvis, okay? Now when you look at a moderate flexion, look at how much more of the pelvis is, the baby's head is coming through the pelvis. You don't see a bunch of room, right? Okay? That's the military position. So you go from flexed to just looking straight ahead. That's why we call it the military position, right? When you're right at, standing at attention. The brow presentation is almost, it's just before complete flexion, or what we call extension, right? And look at how much is coming through. Plus, you've got the issue of a face coming through as well. Those are pretty tough to navigate. That baby is pretty stressed at that point. And then you've got a baby that's already in full extension, and the face is coming through. All right, another one, a rotation abnormality other than deflection, is a breech presentation. All right, so what you have to remember is the risk for cord prolapse. Okay. And what that is. And so if you ever want to watch a great breech delivery, I would love for you to look up Call the Midwife and type in the breech delivery. It's actually very, very, very good. It's well done. And it shows exactly what you have to do, which is nothing. It's very interesting to watch as the baby's coming out that you are not allowed to touch it as it's delivering. Why? As soon as you start touching the baby, it's going to want to start to extend its head, and and the biggest issue is head entrapment. Okay, so if a baby's head gets extended, it's going to hang on the pelvis. Okay, keeping it flexed. Okay, you really don't touch it barely at all. It's a great watch. Probably can see a couple of them on YouTube as well, but this one is clean and it's got enough energy that you're like, whoa, this is stressful. Okay? We don't do them very often, so we're not all well trained. Person comes in breech that is not in labor, we're going to do a C-section. However, a person comes in breech that is in labor, and that butt's already coming down, we're going to deliver it. We're going to deliver it. Okay? So we're trained enough to know what to do. It's delivered usually in the OR. Okay, so we can do something.
Like when it's coming out, the hair gets stuck.
Only if it goes from being flexed, right, to deflexed. That's why you don't touch it. If you've got a footling breech, you can't deliver it. You only usually can deliver those frank breeches pretty well. Sometimes a full breech, okay? But the key is that cord too. Head entrapment and cord. Can't do it. C-section. And it's, yep, just pull it back out. And the hard thing with a C-section with a breech baby is making sure the anatomical parts are out of the way. Okay? Right, when you do get in there, because they're going fast. They're going to go fast. Okay. All right. Breech presentations are just only about 3 to 4%, so it's pretty rare. When you think about an OP baby being at 25%, these are pretty rare. Okay, everything's slower. And you can try to turn the baby, called external cephalic version. Okay? So you'll try to turn the baby and keep it there, but then we'll put them into labor pretty quickly after that. Right? Just remembering that when you think about what's larger, right? The head or the bottom. the bottom. It's going to be larger, which is a larger diameter. The head's more, it's more harder of a surface, but the bottom is going to be larger diameter, so it's pretty hard to work that through. Okay. All right, all of that. Yeah, and the biggest fetal injury is with a vaginal birth, and so that's why we don't do them as often, only if we have to. All right. This is what it looks like when you're going to do an external version. They relax the uterus with terbutaline. They monitor the baby the whole time. And about 3 providers are in with you, 1 nurse and sometimes 2 physicians or a nurse midwife, and we actually rotate the baby. And we push the baby and we figure out how close on either side it is, right? And we start to rotate it and we keep rotating. And then the baby eventually turns. It doesn't happen all that often it's successful, but we do try it. Okay? We do try it, unless they're not a candidate. My last one, Gracie, was a breech for up until the 36th week, which is pretty abnormal. I didn't have any other babies that were breech. She just got stuck in that position. I was not a candidate for a version. Okay, I didn't have enough fluid, and I had a very small uterus. Okay, and so I just the size wasn't large enough, and I didn't have enough fluid. You got to have good fluid for this. So we did all the other mechanisms. She ended up turning. I did a lot of hands and knees at night, and I would switch my positions. And I did a lot of midwifery techniques. There's a couple different things we can do, and the baby did turn. So I did have her vaginally. Okay. All right. What are you going to do? You're going to get an ultrasound for her. Present. You're going to have an IV. You're going to give her terbutaline. You're going to watch that mom's heart rate, baby heart rate. The baby and mom will be monitored for about an hour. And if everything's successful and everything goes well and the uterus stops contracting, sometimes they can be sent home. Sometimes they'll go right into labor. Okay. This is one of those where we're manipulating everything, right? So we're going to give her Rogam. Okay, we're going to give her another dose of Rogam. Okay, remember that for the RH incompatibility. All right, so another complication is just multifetal pregnancy, right? Those are the ones that don't engage well, right? That's cephalopelvic disproportion just right there. If you have a baby that is vertex, the first one, and the other one's going transverse, sometimes that second one will turn very beautifully and have a vaginal birth as well. We do give them the option of trying for a vaginal birth, okay? That's kind of fun, right? But we might be at risk of doing one vaginal birth and still the other baby having a C-section, because we can't get that other one. Sometimes it takes an hour or 2 in between births, sometimes even longer, sometimes it's 30 minutes, okay? It just depends. These are the types of babies that are born always in the OR. Always in the OR, even their vaginal, that first one, if it's vaginal, then so that we're prepared for a C-section. Okay, and just pay close attention to what type of placenta you have, okay? Whether you've got dizygotic twins or fraternal, okay? And so you're just watching for that placenta. All right, so of course, multifetal pregnancies are you have a lot of discomfort going into birth, right? Going into labor. And then you might have this issue where you have one vaginal birth and one C-section, okay? The biggest keys to this is just remembering that they're at risk for hypotonic contractions, okay? Large uterus, so they have possible hemorrhage, okay? They are at risk for having a cesarean section just because that uterus doesn't work very well. Some of them might be at risk for hypertension or maybe even preeclampsia. And the biggest thing that we watch for is preterm birth, because that uterus gets big quicker. Okay? Sometimes you might have a baby that's growing really well and another one that isn't. Okay, so we can't have IUGR or intrauterine growth restriction on one baby, maybe on 2. It depends on how the placentas are working, or maybe just one is getting all the nutrients. Okay, you've got these babies that are not the same size. Maybe one's a whole pound and a half bigger. Okay. All right, so sometimes that happens. All right, so this is what they look like. Okay. Right? Sometimes it can be one's just a little bit ahead of the other, right? They're both head down. They're pretty intertwined, so they can. It's pretty hard to get them, do too much. But we have enough vaginal births on twins that happen all the time, so it can be very successful. All right, let's go into this next emergency, which is prolapse cord. Okay. Usually it has a bunch of those P's involved, right? You got the powers, you got the passage, and you've got the passenger. Okay? Powers is most often this happens with an amniotomy, so rupturing the bag of water, when the head is not engaged. And it's a big no-no. And as a nurse midwife, I was not allowed ever to rupture a bag of water if the head was not engaged. It's out of my scope of practice. That means it's an abnormal birth, okay? Now, if I needed help with that, I'd get my physician colleagues. Let's say we've tried everything, and this is the last effort to get this baby to come down. I can get some help with that. However, if I've got a lot of fluid before the baby, that's why I want to really feel that fluid before I rupture the bag. That's why I want to know what's going on during a contraction, because I can feel that cord, okay? Now, some people have said to me in class, well, don't you just do an ultrasound so you can see? And we don't. We don't do that. Okay? That's not what we do. Even if the cord is near the baby's head, most often it doesn't come down before it. Okay? So if we do feel a pulsation or any of that, then of course we wouldn't do it. Okay? So we assess that pretty great. If the baby's higher in that blottable area, right, above -2, -3, in that area, that's going to be a big issue for prolapsed cord. Some women come in, or they're sitting in their bed, or they get up to go to the bathroom, and their bag of water ruptures on its own. And then all of a sudden, you might be out at the desk, and you can see the fetal monitoring strip, and all of a sudden you see a big dip of the heart rate. And that causes everybody to run in, and then you say, okay, I'm going to do a vaginal check. I want to see where you're at. And then you open up the sheet to do this, and there's the cord sitting right in the bed. That's what's happened most of the time for me. Okay? Now, what happens when that happens? You stay very, very calm, and you say, all right, what's happened here is I can see that the cord has come before the baby. So nowadays, about 10 years ago, we used to hide everything and not say anything in the labor and birth for a mom, and it's gone back and forth. Now we actually are trained to say everything we see so that mom knows exactly what's going on. So I would say, okay, I see a cord here. I'm going to call for people to get in to help me. So you would stay in the room. You would get your call light on, okay? But the very first thing you would do before ever thinking about if your first step is elevating the head outside of the pelvis, okay, as much as you can. All right? And that's where you sit there on the bed and you do a vaginal exam and you elevate the head, okay? Now, you're wanting to also get that head, if she can move, you want to get her bottom higher than her head, right? So you're going to put her in the knee chest position, and you can actually push that baby up that way too. If she cannot do that because of an epidural, it's you in the bed until the cesarean section happens, okay? We call it finders keepers, okay? You literally ride the bed till the C-section's over. You don't touch the cord at all. If you touch the cord, it can spasm. So you actually stay away from it. Now, sometimes your hand naturally is kind of laying on it. This is a couple cases that I've had where the hand is laying on it, and I can actually feel it pulsating. So I can call out to everybody, I've got 120 beats per minute. Or I can tap my head to the beat of the cord, and everybody can see that the baby's doing fine. Okay? You stay on the bed, and then it's an emergency section. They actually do put you under the drapes. Okay? And they will do an emergency section that way. Okay? So that's how that works. Okay? So you can be at risk for this for a very small fetus, a breech presentation, any baby that has a transverse lie. Why? Because the head's not engaged and that cord's going to fall through possibly. Or if you have too much fluid. Okay? All right, so this is kind of what it looks like. Okay? The one that is on the far right is that complete prolapse cord where you can see it. Now the other two are called occult or hidden cords. Now sometimes the head's presenting and you can't see the cord or feel the cord, but when this is happening, when the baby's heart, when the contraction happens, the heart rate goes down when the baby's being pushed down the canal. Okay, so that's, you think, oh, it's usually a cord compression. Okay, so the head, as the head's being pushed down, the contraction happens, right? And the fetal heart rate goes down, so they mirror each other. Mirror each other. All right, and then sometimes you're like, you have the same thing, you see the fetal heart rate is not doing well, you run into the room, you do a vaginal check, and you go and you can actually feel the cord. the rope light cord. Even though it's not presenting like that, if you can feel it, you lift the head up and you stay. The baby cannot deliver through that cord. Okay? That is very different when you actually have a head that comes out. So as the head comes out, the very first step I do for all births is do a quick sweep. And I will sweep around the neck just to make sure I don't have a cord. It is not an emergency if you have a cord around the neck on a normal birth. It happens about 30 to 40% of the time. You can just reduce it or push it around the shoulders, okay? We're all trained to do that. Sometimes it's too tight, and we have to cut the cord right there, okay? So we have to clamp on both sides and cut it and then deliver very fast, all right? But usually that's not an emergency, okay? It feels like it if you have to cut the cord at that spot, but it's not, okay? It's not like you have to get everybody in. You just say what you have. All right, call for help. We've said that. Give explanations, reduce anxiety. The biggest key is to remain calm, to state what you're doing. Some people like to talk things out, and other people don't, right? If you're stressed, you like to keep it all in. The way I keep myself calm is just to run through what I'm doing, okay? And telling people, to make sure to keep track of time and to be documenting. And just stay real calm. You might feel really stressed inside, but you don't let anybody see it, okay? We talked about all those things. Oxygen. Good to get oxygen. And sometimes we'll do terbutaline if we've got a lot of contractions that are happening and she's really uncomfortable, okay, just to stop that. We'll stop the Pitocin, things like that. This is not, again, the case where we have time to wait. It's an emergency C-section. Okay? The only reason I would ever do a spontaneous vaginal birth is if the baby's confirmed dead. Okay? So if there's been a fetal demise, then I can deliver the baby vaginally because I don't have any concerns on the cord coming before the baby or any of that. That's the only way that I would do a vaginal birth in this case. Okay? And remember, we're going to talk about fetal demise and some fetal loss and perinatal loss in the next few weeks. But remember that we will always encourage a woman to do a vaginal birth, and that's how we do it, and not a C-section on the loss. Okay? Because that's a very traumatic thing to do a cesarean section on somebody that has a loss, because you could have infection, you could have a couple different things. So we will have them do a vaginal birth. Some of you might see a fetal loss on the birth unit. Okay, so I just want you to be prepared that they will be delivered vaginally. Okay? It'll come out just the same. It'll come out. We'll induce it, and it'll come out within 30 minutes, just like it would on a normal birth with a baby alive. The blood is still flowing, just the baby's not living. Yeah. Okay. We'll talk a lot more about those in the next few weeks. All right. This is what the mom looks like. Remember I said she's going to get on hands and knees? Okay. And the biggest thing is to get that head elevated off the cord, out of the pelvis. Okay? Good. All right. We're getting to the end here. Psyche. So one of the things that I've talked about, I'm not going to do a ton on this one. You guys can read it because I want to get to my other slides because I've talked a lot about it and interwoven it through, okay? The biggest thing that you have to remember here is that when a woman is stressed or she's not resolved in some way or she's tired or any of these things happen, they need to have the experience of allowing to either express it or for us to ask them, what's going on? You seem very upset. I want to hear a little bit about it. Sometimes it's just somebody in the room that they don't want. It might be a mother-in-law. Might be somebody that's just overstressed. Maybe that relationship with that partner isn't going well. Maybe it's been an abusive relationship and they just can't get through it. And sometimes you can ask them, what is it that you need? Can I help you? And sometimes they'll say, yeah, I really need you to get my mom out of the room. I just feel judged by her. I need her to go. And you'll remove that person out and they'll start going into labor better. Okay? Anytime you've got a prolonged issue, you're going to have a prolonged labor. Kind of like mine. Remember my case, okay? All right. So induction. Induction is when you actually have oxytocin present, okay? All right, to get contractions moving. Okay, oxytocin is the name that we use for both endogenous and exogenous hormone. Okay? It's the great love hormone. It's present in lovemaking. It's present when you have good food. It's present when you feel happy. The love hormone. It also helps with contractions, and it is a bonding that happens with your baby as well. So those that have good contractions will have, there's some research that says that they have better bonding if they have labor. Okay, so those that have repeat C-sections might have a little bit difficult time to get that bonding started because they didn't have the contractions. So induction is when you have no contractions. Augmentation is when you have some contractions, and you're just augmenting them. That makes sense? Okay. Two different kinds of ways to do it. A couple ways we can do it. If they're greater than 42 weeks, we're going to do that. Most of the time, we don't induce just to induce. However, we have a few more women that we can do this for if they are ready to give birth, and they have what's called a Bishop score, or their cervix is ready. Okay. There are reasons, though, to induce for comorbidities, a uterine infection, preeclampsia, diabetes, something that's severe, Rh disease. We're not going to keep them pregnant if the milieu of the baby isn't doing well with the mother. Okay, so there's reasons for that. For the baby, growth restriction or too large can be a reason for that baby to be induced, or if the fetal heart rate tracing is abnormal. Okay? Sometimes there's non-medical factors, like sometimes people are being deployed, and so we'll consider that. Okay, we'll consider those types of things. Okay? Not very often, but we do consider them. And the only reason we do it is when the baby is, we wouldn't keep them pregnant because we can't keep them going in labor because enduring that would be bad for the baby. Okay? And then any other contraindication would be for mom. So if you've got a congestive heart failure of some sort, or an anomaly that's greater than 20%, 30% of the heart, we are not going to put them through labor if it's going to be too hard on their heart. Okay? Okay, lots of different ways we can get people to start to be induced that are not by oxytocin. Okay? You can do a castor oil. Some people say give an enema. Because it all starts the contractions a little bit. Lovemaking is probably the most common used prior to going into labor. We would say make sure you have intercourse. If you do, make sure you orgasm. Make sure you wait. Okay? Just so that you guys all understand, semen is a prostaglandin. Okay? And when you have lovemaking, oxytocin is that's what happens for orgasm. Okay? So that's why we do that. So very medically, we encourage that if they're up for it. That's probably the number one way we would have people do that if they're up for it. We can also do the same thing by stripping the membranes of the cervix, where you actually go inside the cervix and you get to the internal os and you actually strip the membranes. It's a little bit uncomfortable. You can have a lot of contractions from it. Oxytocin is ignited when that happens, and it can cause them to go into labor or at least soften their cervix. You can use a Foley bulb to put inside of the cervix. Okay, we have a better one that we do now that's a little bit smaller, but we just gently open that cervix and it causes contractions. You can do nipple stim, but we don't usually recommend that in the hospital as much because it's hard to control. Nipple stim, again, same thing, oxytocin's ignited. Okay? And then, of course, you can give oxytocin. That's your endogenous or exogenous way of getting contractions moving. It's so potent. It's very, very little bit amounts. And as a nurse, that is your medication that you're fully responsible for. So if you up it and anything happens to the baby, you would be having to explain yourself on a witness stand. Okay, so why do I tell you that? It's because there's usually orders that are given to you, and it's a delegated order from a physician to say up the Pitocin at, let's say, 1 milli-unit per 30 minutes. But let's say she's got adequate contractions and she's dilating, and you up the Pitocin anyway. If anything happens to that baby, you will be deposed. It's called a high alert medication. For that reason, you have to document on this a lot. So one of my rules when I was teaching nurses how to use this medication for 7 years was make sure you only up it when it's necessary. Okay? All right. Even though the physician says you were supposed to up it, and you would say, I did your order, he would say yes, but you were to show you were to determine whether or not it was needed or not. Okay, so you won't be protected by just the order. Okay? This is called a Bishop score table. This is how I know the cervix is ready or not, and if I can give oxytocin. What it looks at is whether or not where the position of the cervix is, how soft it is, how effaced it is, the location of it. Okay, position, consistency, station of the baby, effacement, and dilation. 5 different things I measure. Okay. For a mom that has never been pregnant, or never had a birth, I should say, never had a birth yet, vaginally. So if they've had a C-section, they would be considered an essential prime para. If they've never had a baby, I would look at their cervix and say that it has to be at least 5 or greater. Okay? At least. Okay? I'm sorry. If they've never had a baby, it's greater than 9. If they have had a baby, it's 5. Okay, 9 or greater. Okay, vaginally. Why is it less than if you've already had a baby? Because the cervix knows what to do, and it'll go a little faster. So I can apply Pitocin at 5. Okay. All right. So there's a couple different cervical ripening agents other than prostaglandins that I've talked about that are natural, like semen or low-dose oxytocin. We can do a couple different things. We could do Cervidil. And so one of the things that we do for that is we just place that around the cervix. So let's say someone is remote from delivery, meaning that they're like, let's say 37 weeks, but they have high blood pressure. We can't give them Pitocin right away. We'll give them the Cervidil. Okay? And we'll watch them very closely. Okay? Monitor them. The biggest thing I want you to remember about oxytocin, because it's a high alert medication, just like what it says, it's always administered via a secondary line, not your primary. And it's given to the closest port. And that's so that we don't bolus it. So there have been many cases, unfortunately, where a nurse thought that she was opening up her IV line and taking something off the pump. Like if, let's say she had both on a pump, and even though one was on a pump and one wasn't, it's clearly labeled, but in the stressful moment, you got a lot going on. But so she unlocks the Pitocin and she opens that up. Okay? What happens right away is the uterus clamps down fully, and we rush to do a C-section. There's no way we can stop that. Okay? The half-life of Pitocin is 7 to 15 minutes, up to 30 for the last site to be removed. I will not be able to correct that in time to help that baby, so usually it's a cesarean section. Okay? That's why you do it on 2 different lines, and you label it very closely or carefully, and you understand what you're doing. And it's on a pump, and it's ran 1 milliunit, okay? 1 milliunit per minute in usually 1,000 cc bag. That's a very, very, very dilute amount of medication that's very potent. As soon as you give it, contractions start. Okay? All right, you're watching for hyperstimulation, too many contractions, and hypertonus. Okay? So too many contractions that have a lot of force. Hypertonus is too many contractions that are just piddly, but they're not allowing that uterus to relax fully. Okay? Pitocin given over a long period of time causes water intoxication, so too much, so the woman will retain fluids. We don't see that as much anymore because we don't have long inductions, because now we time them better by that Bishop score. But that can still happen on our long inductions that are preeclamptic. Okay? So it gives you a bunch of signs and symptoms for that. All right. This is an important slide. Important slide. Okay? When you are thinking about somebody who has too many contractions, let's review the fetal monitoring strip here. So here you have on the top of the line, what is that? Now that everybody looked at the fetal monitoring strips and we're ready for class, what's the top line? The heart rate. Twin Cities? What's the top line? Fetal heart rate. Okay. We love to see it in between that blue line. That blue line is present now on most fetal monitoring strips. It's telling me that the baby, if it's in between that blue line, that it's doing pretty good. We like it to bounce in between that blue line. Now let's look at the bottom one. What are those? Contractions. Okay? So what's important to note here is how many are occurring. So I want you to pay close attention, and when I say that, that's important, to that blue area right there that says uterine hyperstimulation is defined as greater than 5 contractions per 10 minutes. Okay? Right? And we look over a 30-minute period, but if we're already seeing it in 1, 2, so red line to red line is how much time? Who can tell me that? Who did the work today? Red line to red line. 1 minute. The little ones in between are how many seconds? 10. So important. So what I look at that first contraction, from the end of that contraction, remember when I told you about tone? If you look over to that right side, you can see that there is tone listed there, right? That tone's in that 20 range, right? That's my highest level of tone. I want it to relax a little bit further. I don't like this right now because the tone's getting too high. Why? Because there's too many contractions. The uterus is not fully relaxing. What's happening in between is when you see it kind of flatten out in between. When you see a flat area, you can count the amount of seconds that the baby's able to breathe. If it's less than 60, that baby is not recovering. So how many seconds is in between that first contraction? Maybe just give it an eyeball. 30. How many? Does anybody know? Somebody said 30. Who said 30? Anybody? 30? About 30 seconds. Okay? The rule of thumb is every contraction in between it, it needs to be at least 60. That's important for you guys to know. Okay? That's so the baby can breathe. There's too many contractions here. Look towards the end. That uterus is not fully relaxing. That baby doesn't have any breathing capability, hardly at all. A little bit, but not much. Okay, so we're going to start seeing the baby's heart rate looks fine now because they're already over-oxygenated. They come in to birth well oxygenated. They can tolerate this for a little bit, but not for long. That's why you only have a certain amount of time for hyperstimulation. What do? You're going to turn off the oxytocin if it's going. Number 1, if you see too many contractions, turn it off. Right? You're going to see what the baby's going to do. The baby should, at that point, as soon as the oxytocin is turned on, how much time do we have? What's the half-life that I said? 7 to 15. And so what happens, just so I can teach you really quick, you don't need to know this. The way oxytocin works, there's certain sites that it binds to in the uterus. If you give too much oxygen, you got too many of it, it gives you really uncoordinated contractions. If I give just a sweet amount, coupled with the fetal cortex, you need about 6 to 8 milliunits, okay? Fetal cortex contributes, so does the maternal cortex in active labor. Usually I need about 6 to 8 total. If I'm up at the 15, I'm going to see these uncoordinated. But I'm also going to run into the problem that if I turn it off, I'm going to have issues with different sites leaving at different times. That's why I say up to 30 minutes, okay? Is that important for you to understand half-lives of medications as nurses? It is. For the purpose of the test, I don't necessarily need you to know that, but oxytocin is one of them that you have. If you do labor and delivery, you got to understand this and how to run it. That's why I train people and train physicians now on it too. All right. So you're going to do a lot of different things. If you have hyperstimulation, you are going to turn the PET off. You're going to make sure the fetal heart rate's coming up. You're going to turn a right to left side. You're going to get your people in the room. If it is not coming up, if it's down below that 100, you're going to get more people in the room. You're going to start preparing for a cesarean section. You only have a bit of time, okay? Right? Once that baby's heart rate is below 100, you're going to want to get that baby out between 3 to 5 minutes. That's from noticing it. That's how quick people can get people out. Surgeons can get these babies out in 3 to 5 minutes. Okay? You're going to increase her fluids, and if she doesn't have a second, a large bore IV, at least 18 gauge, you're going to want to start another IV. You're going to put the oxygen on, and you're going to then notify the provider. Once you have a full assessment, you'll notify the provider. Make sense? All right, so what are the complications? I'm just going to, let's see if I've said any of these. Okay, biggest thing that I want to focus on is the uterine rupture. Too many contractions over a long period of time can cause the uterus to rupture. Okay. All the others we've kind of talked about. It's just a cascade of events. So oxytocin, there's a sweet spot. Too many contractions can cause this to happen. When you have too many contractions, then you have fetal distress. And then when you have fetal distress, you have hypoxia. So if you see a contraction pattern, there are too many contractions, your first thought is what about the baby? It's not able to breathe. it's at risk for hypoxia. If it gets to be too far into that, like let's say that 5 to 6 minutes, then we move into hypoxemia, right, to the tissues, a little bit further. Hypoxia versus emia, right? Hypoxemia versus hypoxia. All right, so with a post-term pregnancy with this, we do have these happen, right? People go too long. I often explain to people when they say to me, why am I not going into labor? And it's like, well, there's just certain times that not everything works in nature like it's supposed to. Not everybody has all the mechanisms in place, the hormonal structures to put them into labor. It doesn't mean anything bad, okay? Sometimes you'll go to an apple orchard and you'll see a bunch of apples still on the tree just rotting. They never fell, okay? Something that happens. We have hormonal structures already in process that doesn't allow us to do that. It's not a problem, but what we have to do is make sure that the due date's correct and that the placenta is okay, right? And then we get an induction. We kind of like everybody delivered really by the 42nd week. So if somebody is already 41 plus weeks, I'm going to start doing a couple things to get them ready for birth, okay? Because we know that placenta ages quite a bit. Those calcifications I talked about with with Sophie on my third one, she was only 38 and a half. That placenta was aging very, very quickly. I was stressed. Okay? So I'm going to pay close attention. You look at the complications of a postpartum pregnancy, most often people are pretty fatigued, sad, overwhelmed, wondering what they're doing wrong, and then they have all the other side that are the fetal neonatal. Okay, you could get cord compression, the large baby issue. Maybe the baby might poop in the fluid, meconium stained fluid. And then when you think about anything greater than 42 weeks, the post-maturity syndrome happens. So you get a lot of different things that can happen. They're not getting enough nutrients, possibly. Maybe they might lose weight. Okay, if the placenta is not working well, something else, a couple other things might go on. You might think about infection might happen. So there's a couple different cascading of events. That's why we like them born right at the 42nd week. Okay? Doesn't happen very often, but we do see it. Especially with those women who are absolutely 100% telling you, you will not induce me. I'm going to wait till this baby comes. Okay? All right. A couple things on this slide. Just make sure you understand that when you have a late-term pregnancy or a post-term pregnancy, we're going to monitor them. We're going to do bi-weekly non-stress tests and a biophysical profile, which is monitoring the inside milieu of the baby coupled with the non-stress test to equal a score of 8. Breathing movement, fluid, non-stress test, and cervix is also going to be measured. And you might even have Doppler flow, measuring the blood pressure of the placenta like I talked about in the beginning. Okay. The key here is that the mom tells you how well the baby is moving. So you want to have a number of times where that mom's sitting down and getting fetal kick counts. We start that right around the 25th week when the mom can really feel the baby kicking. We get them really in tune with how much that is, and towards the end, it's a number one indicator of fetal well-being. And so if a mom comes in and says, I haven't felt my baby move in the last day, that's going to be big and concerning. First thing you're going to do there is what? If someone comes into your triage unit, she says, I haven't felt the baby move, what are you going to do? What's the first thing you're going to do? Put her on the monitor. There is a no, stop, go. There is no, like, wait here for a second. I have 4 patients ahead of you. None of that. You will find a bed, and you will get that done immediately. Okay? All right. And if, like I said, if their cervix is not ready, you're going to start preparing them to have some sort of cervical ripening agent right away. Okay? All right. Last few slides. So when is a neonatal resuscitation team needed? Okay. Well, we talked a little bit about this. You have a couple things that you can anticipate, and some things you can't. Okay. And so one of the things you want to ask yourself, is the baby full term? What's the color of the fluid? Is the baby breathing? Is the baby crying? Okay. And then also, one of the things we have to ask is the baby have good muscle tone? Now, all of that is done while the baby's on the chest of the mom. Okay. You give the baby a good minute or two to pink up. Okay. We don't whisk the babies away anymore. We used to just cut that cord and go to the warmer and start doing all these things. And we were just angry, mean to these babies. We don't do that anymore. They do that at Mayo still?
They take the baby, go straight to the wall.
Oh, for the... Well, should not be doing that. Okay? Okay, they should not be doing that. So that is just not even evidence-based anymore. We do complete right away up to the chest, most so. You can stay curious and say, now tell me why you don't do skin to skin immediately after birth.
After they do the APGAR
Yeah.
and all that, then they do the skin.
No, because that breaks so the baby is supposed to only smell the mother first. Yeah, it goes right up, and so that is something.
And you can do an APGAR while the baby's on the mom's chest.
Right. You do APGAR everything. You listen to heart rate. You wipe them off. You remove that. You get them all cleaned off, right? Because the baby is literally like in between the breast and down by the uterus. You want their little feet down by the uterus because they will stimulate the uterus. It's very amazing. It's amazing what happens. There's a couple different videos I can show you. I wish I had time. And you let that cord stay connected until it stops pulsating. Okay, it's called delayed cord clamping. Okay, and that might be 2 minutes, might be 3. And then once that happens, you can bring that baby up a little bit more, but only 12 inches away so that baby can look at mom. And if they intend to breastfeed, that's when you start thinking about it. But you let that baby just kind of smell and do all that. All that can be done on the chest. Even if you have, a baby that's just extended and stunned, and we give it a lot of time. They do much better on the mom's chest than they do over on the less interventions. Okay. So you got to go through all these little steps. There's a lot of things that we do now. We allow for a lot more than we ever used to do on this. Okay? Yeah. We do allow in most hospitals now, in different cities, I know that they will see that. If a baby comes out and we know there have been like a turtle sign, right, the shoulder dystocia, I'm going to be anticipating resuscitation. I'm not going to mess around with that baby. Okay. They're not only stunned, they're unable to cry at that point. I'm going to have to do what's called positive pressure ventilation, PPV, to do the initial opening. Because what happens when you clamp the cord and you take the first breath has already happened, and they weren't able to have that happen. That force, I used to memorize the force that they believe that is, but that very first breath and the opening of the PDA is so great that that's what opens everything up and the baby's able to breathe extrauterine. Okay. Same regard when you have a water birth, the baby's born in the water. It's fine. It can float all around. Once you lift that baby up, then you're going to not put the baby back down. Okay. They'll take that very first breath. Anytime, have you ever held your breath for a long time underwater and you come up and you're like, like that? That's the force that happens. That's what they do. Okay. That if we lose that opportunity in a very traumatic birth, I'm going to have to create that myself. I don't have much time. Okay? Right? And as a labor and delivery nurse, you are trained in neonatal resuscitation. If there is no neonatal nurse practitioner present, you need to be able to do it. Okay? Okay? All right. And if you're the RN and you have a traumatic birth that's happening, you can get some team of nurses there. Okay? That can help you with that. They'll all come in. All you say is, we've got this going on. Everybody comes to these kinds of things. This is a party. Not the party you want to usually attend, but it feels like one. Okay? It feels like a party of people that are just there to help. And they do. Okay. This is just another summarization of kind of going through yes or no, whether or not you need to resuscitate. I put this together just so that you can see what the initial steps are. That's heart rate. You go to ventilation and chest compressions after that. Okay. Not last semester, but the semester before, I did have a couple nurses that had seen a resuscitation. So that might happen for you, maybe in a C-section or maybe on a vaginal birth. So just being prepared to watch what they do. Okay. All right, and the last slide is just talking about some of the things for normal birth, just to keep in your pocket. Some of the things just to remember. This is from the ACNM. These are the things that we call normal physiologic birth, that women who want this, these are the types of things that we really honor, okay? But sometimes we have to induce. Sometimes we need to apply oxytocin. Sometimes things happen differently than what some women want. But these are the types of things that are utilized for normal birth, okay? We don't rupture the bag. We allow for a lull period second stage. We allow the baby just to move its way down. We delay the cord clamping. We do skin to skin, all that kind of stuff. If they don't want IV fluids, we don't give it to them. They have to qualify for all of this and be very healthy, but we do this pretty well for most people that want to do it. Okay? All right, this ends this set of slides. How many questions do I have? People excited? How many want to give birth, right, or begin a birth after this? All right, no?
We have 1.5.
Excited about this now that you have 21?
I think we only have 1.5 people in the class that raised their hand.
Okay, so did I deter anybody from going into labor and delivery after this lecture? No?
No, I think it was more great birth control method.
Oh, I love it. Okay, yeah, that'll help. All right. What we're going to do, yeah, that'll work. My next set of slides won't take me a ton of time, okay? So let's take a 10-minute break. Be back right at 11. We'll get going, okay? Because the last 2 minutes, right at about 10:12, I want to be going over all the fetal monitoring sections, okay? 10-minute break, okay?
Oh my God! It's so far.
C-section sometimes.
I'm really like,
What's your wife's name? Put another one again. We almost had 3 dogs. And I did start putting up, and I love you. Yeah, I did not want it. I like really started crying.
it's just like,
Gosh, the line came so bad. Actually, the doctor set it up.
rough life.
So this was they both do it. It's strict.
If you had medical powers,
Right.
you're trying to get to the sauna.
The first one wasn't exactly happy.
So the duration is
You're going to very dramatic. I feel like they haven't even made me see that.
I know.
No, I didn't. So far.
Let's put it out.
Yeah,
there was no
is
dialogue.
there like an autumn?
very expensive.
Okay.
Okay, well, I'm gonna start a countdown, I guess. Yeah, opens November 26th.
Oh, that does sound good.
Thank you.
This is making me so anxious. It's just like odd. Oh, the juice is no, it was the first minute. It was start of 1.
How long is it gonna be?
2 minutes and 45 seconds.
Yes.
All she said was like, it's about women.
To the upper body.
No, and then she has a video of it.
It was like, it was about money.
Oh, no, yeah, I'm sorry.
No, but I had a really good one. And there was a Republican. Pull out people. Like, she has a point. Like, good for her.
Oh, you texted her?
No, I called last night. I'm not gonna
Like, now.
the rest. You don't know. But
History of the world, I guess.
I'm like calling my grandma. I said happy birthday, grandma. I'm saying no, thank you so much.
So infuriating.
You were very close. What is something? She goes, Emma said, "Good for you." She goes, I hope it's very kids from like. We also
Okay, but now I have to. No, I need it.
because it's easy to
What's the video?
Best. You said that because this is and he posted the video. It's like best of so that they can listen. It's like an early piece, so that on the day of.
That's what Lush again.
Okay, you know me at my internship. Something I would drink you. So the door probably should have grabbed someone else for this.
No?
Like cheesy. It was like minions club. Other than just like stuff got because it was like I asked her, I'm gonna make an email and she sent me an email saying like, oh yeah, the content hurts. Okay. So basic stuff. No, you say like, yeah, you put yours. I accept. I think so. I know. Don't. He's good. It's good. All it said in my like comment from there's going back to that's when I go.
John last night at yoga.
How long?
I was really good.
I have to find out.
Stilettos.
Have you ever done this?
Wait, is that where your heels are lifted up?
Yeah, like we did it with like weights, and we like go like themselves together. Oh my! I can like listen.
Why would you
First
use
year
like a
like
wedge on your heels?
I want to know my schedule. Just summer.
I think because it wears your feet so much. But yeah, at first I was like, oh yeah, this is not definitely a workout.
Yeah, I feel like exercise is important.
It's supposed to like
But obviously once you're
yeah. Man, I am not.
What is that?
Oh no, I'm not doing that. No, we're not doing that. So that was the first and second.
The only one
I just don't know. Yeah,
I just heard the word.
Ryan, how did you do on it?
Oh my god, no, we're not doing that.
I'm sorry, but if you're having
This is what I do.
There we go.
No,
I want to see your moves.
I know.
May 6th, I will receive it. When I was calling my mother, I was like,
Double click.
Yeah.
so we went to
yeah, so you
then I'll come later, and I like the one, but I obviously really excited. He was okay. I didn't want to know.
this is my favorite picture ever.
Oh my god! Yeah, you got switch. Yeah, you got
So cool.
So hopeless. I didn't done this dance like so here was that to like bring everybody together.
You know, at least a couple times. Otherwise,
Everyone that's there. I definitely I got in the car and I well, you know, every hour. Oh, we're gonna get on stage. The yoga like no, I think there's like come on. Which one? It's like very no, it's not as like tight. You know, it's more like the last like yeah, come on guys. I was so I feel like I miss so much that there's so many wow. That's very good. I know. Or Sally.
where's the game? So it's like 5 minutes.
Come on back, guys. People,
Good conversation. All right. So we're starting here on just different types of pain control, okay? And there's a couple different things that we want to remember here. That if you're not prepared for the pain, or you haven't at least done some work on the pain that you might experience, or even if you're a little nervous about the pain, right? You could be in some big trouble if you kind of come into labor and aren't prepared for it. Okay. The issue is that with this type of pain, there's no way to get people totally ready for it. They can talk to some people, and everybody has different subjective viewpoints of pain. Okay. So one of the things that happens with some women is that they're so fearful of the pain that they're anticipating that next contraction. This can cause a bunch of different things that go on in the body, right? So we want to make sure that we help them understand that there's no way for you to totally predict how this is going to be, and you can't even do it with each and every labor that you have. So it's just almost allowing this sort of freedom to just experience it, and that's really hard for some people. It is subjective, like I said, and it's very personal. Some people will come in and they won't have any fear of birth, and they'll just understand that this is just what I have to go through, okay? Different religions have different feelings about expressing pain, feeling pain, complaining about pain. And in our culture, we're a little bit different in terms of, very set on absolutely I don't want any pain, right? Or some people will say, well, I'll just take one contraction at a time, But the people that are so dead set about not taking any pain medicine and not being open to pain medicine are usually the ones that are going to have the most issue with going through labor, okay? So there's usually about 3 different types of people that come in. And one says, I'm going to take, come in and I'm going to take one contraction at a time. And if I need pain medicine, great. If I don't, great. Okay? Those people take up about 30% of the people. There's about 30% of people that come in and absolutely will say, do not give me any pain medicine. If I ask you for pain medicine, say no. Okay, those are people that do like the Bradley method, different methods where they talk to their partners, they talk to their doulas and their nurse midwives. Even if I ask for pain medicine, tell me no. Please tell me no. They're just so set on it. Why is that? Because they are looking at how they birth and how they're going to parent, and they have this correlation between the two. And when you unpack that with them and try to get them to sort of understand that it doesn't mean you're going to be a different kind of mother, it's very difficult for them to separate that. And then the other third is they come in and they say, I want to feel no pain whatsoever. Give me an epidural right away. And they're very upset if they don't get pain medicine. Even those that come in like at 8 or 9 centimeters and they've labored quickly and they're driving and they'll say, give me an epidural. Okay? And most of the time we can accompany that. Okay? So a third, okay? Oops. Okay. All right, so there are physiologic effects and there are psychological effects. And I just like to put those in different categories just so you can separate them, right? In the physiologic, obviously you're going to get an increase in the metabolic rate, oxygen demand, they're going to be breathing heavier. Again, no woman is really prepared for this. They think they are, but they're not. Maybe they haven't worked out their entire pregnancy. But all of a sudden they go into labor and they're having lots of energy, lots of stamina that's needing to be used, right? So there's going to be an increase in natural increase of catecholamines. Some of them are protective, some of them aren't. Things like cortisol and glucagon. Glucagon is what is emitted, right, when you've got a lot of stress that's going on. If you haven't ate well for a day and you're going into sort of starvation mode, right, the glycogen and glucagon that's being emitted is stored, right? Those are the things like in your muscles, right? And that's normal to use. Okay, it's normal to use some of those storage, okay? But if you deplete that over time, that's going to be really bad. So these are the kinds of things that just happen naturally, some good, some bad, right? If you're hyperventilating or you're breathing too fast or you're worried or concerned and you're breathing too fast for that reason as well, the oxygen waste, the waste that comes from the oxygen products, the byproducts, right, the carbon monoxide or dioxide, that'll be present. So we have to be able to really calm our breathing down and have people take deep breaths. If they breathe too fast, that's going to be a problem, okay, for the baby, because the baby needs to get rid of its waste products too. Okay? The psychological effects are, there's no interaction with the infant. They might have some unpleasant memories. They might feel that some inadequacies for their partner as well. So if they don't have the birth experience that they wanted in terms of a pain issue, this all could affect their parenting. And this is very well documented. And I don't think we understood it for years, that women who go in and have a birth a certain way actually don't parent the way they want to after it. And so trying to help them, I've always said we should have some sort of mechanism of asking them, how do you intend to birth? And seeing at hospitals how well we achieve that. And then having like a post meeting with them to see how they're doing, okay? There's nothing we can change about this. This is what we know about how these people who intend to parent are really feeling about this, okay? So that's why we're very concerned in anybody that is experiencing pain, whether they're in labor or not. And that's why in the Joint Commission we actually monitor pain very, very closely. Once they say they're in pain, we're going to treat them within an hour and we're going to monitor whether or not it's gone down or not. And we're going to document that, okay? Same for labor. So sources of pain in labor. You've got tissue ischemia, okay, right? That's at the tissue level. Remember when I talk about different terminology? Ischemia is at the tissue. Oxia is not. That's important for you to know because there's pain when it's at the tissue, right? So labor causes pain. Pain you have never, ever felt before, okay? And it doesn't go away, and it keeps coming back. And so what happens is you start to feel fear because all of a sudden you're not able to cope with this thing that keeps coming back. Cervical dilation has pain as well. That's why when the bag of water is present, it tamponades that head on the cervix. So you're not going to feel as much pain, okay? Once the bag of water is gone, you're going to feel pain. The pelvic structures, right, the symphysis pubis, in between the symphysis pubis is cartilage. As already through pregnancy, it's already started to separate, okay? You'll have pain in your pelvis from that. But in labor, you'll have even more, okay? And then, of course, distension through the vagina and the perineum. They often say it's kind of like a ring of fire that feels that's happening when the baby's being born if you have no pain medication, okay? Some people are fearful at that point of the pain. It hurts so much. All right, so in the first stage, you got the dilation of the cervix that's occurring. That's the primary source of pain. You got some hypoxia at the uterine muscle cells during a contraction. Hopefully it's not tissue ischemia that's happening over time. You've got the stretching of the lower uterine segment, like I've talked to you about, as it starts to open, right? You'll get that stretching. And then you've got your lower back pain, buttocks and thighs that are going to be in pain as well. So combination. Some people will say, where do you want me to push? Where do we want me to pull? Where can I massage? And most women will say, I don't know. Try my lower back. Try my hips. Try something. I don't care. It just hurts. It just hurts everywhere. All right? When you think about the physiology of the uterus and the cervix, you've got some pain sensations via the sympathetic nerves. And I'll show you a picture here. Through the posterior segments of the thoracic, 10, 11, and 12. And then it hits lumbar 1. Okay? That's where we're going to try to get the pain sensation to go away with an epidural or a spinal, okay? Because that's where it meets, okay? We want that to go away a little bit. In the second stage, you still got that hypoxia going for the uterine muscle walls that are extending and coming back, right? You got, though, in addition to that, the distension of the vagina and the perineum, and still the lower back pressure, all right? Then when you think about the physiology of where it's located for the vagina and the vulva and the perineum, it's a little bit in the sacral region. So 2, 3, and 4, those roots. Okay, so we're going to try to cover a lot of area and get some pain sensation relieved in those areas if we can. Not always does it work. Okay. So look at what we've got here. When you hit L1, right, if you can get right above that, and down, look at what you can do with an epidural. Right at the tip of the uterus, right, and down, she's going to have some pretty good pain relief. Okay? Right? Makes sense? Okay? So that's real helpful. That's a good picture for you to see. In the third stage, what happens in the third stage, right, that's the birth, after the birth of the baby to the birth of the placenta. Okay? There's a lot of different pains that happen, but they're no different, right? You've got the cervix that you might have a little bit of pain. You might have uterine contractions from that uterus trying to clamp down, but mainly you've got perineal pain. Now, interestingly, a woman usually can go through birth if she's tolerating pain pretty well, and the baby will come out, and then all of a sudden, if you've got this issue where you've got some tears that you've got to repair, this woman will go then from having coped really well with the pain to having excruciating pain, because all of that protective efforts is gone. She can't cope with that. So sometimes I remember as a young midwife, I would be like, wow, she dealt with pain so well during birth, but now in the repair, she's having more and more pain. Okay, we do numb that area. I'll show you a couple ways, but mostly 1% lidocaine with a little shot can help so much when we repair. Sometimes we have to do a little bit more, but usually that'll relieve it. Okay, and then the fourth stage is from after that placenta is being is born through the rest of that time in that first early 48 hours. Okay, 2 to 4 hours is the initial fourth stage, but we really consider that initial recovery, watching them very closely for that next 24 to 48 hours. That's where those uterine contractions come in. Now, the main issue with this one is you get intense contractions right when the placenta delivers, and then they'll kind of peter out. But they'll come back in the after pains of breastfeeding, okay? So when a woman goes to breastfeed, right, then she's going to have contractions that happen, and the contractions get worse with each baby that she has. Okay, so after pains are worse after each baby. She'll have perineal pain and incisional pain during this time. If she had a repair, so you've got all these things going on, and then you've got a repair that's very swollen, she's going to be pretty uncomfortable to be sitting, and you need to do a lot of sitting when after you give birth to breastfeed if you intend to do that. Okay, so we can do a couple different modalities: ice packs, sitz baths, some other things that can help relieve that pain. All right. So then when you think about the factors that influence pain, just remember the intensity of the labor is going to influence it. The psyche of the mom is going to influence it. Her readiness to have the cervix be dilated, right? If you've got prostaglandins on board, if you've got oxytocin on board, what do you have on board? Is it natural labor? The position of the baby, is the head well applied? Is it deep within the pelvis? That's a much different labor than if you've got a baby that's higher. If you've got a baby starting out really deep in the pelvis, got it well applied to the cervix, that's going to be a much more difficult labor, a faster labor. Okay, natural fatigue. How did she come into this? Had she been cleaning the house all day, running around after a bunch of children? Okay, did she work a night shift? Did she deliver babies all weekend? Where was she? Was she ready and prepared? Most women don't get up after a good night's rest and say, okay, it's time to have a baby, right? So they're coming in with all sorts of things going on, right? And as I talked about the psychosocial, right? What are your cultural expectations? What is your partner's expectations? What are your own personal expectations of yourself? You are so dead set not having any pain medicine, and that's all that matters to you. You might be disappointed if you don't do it that way. Who are your support persons? I have one thing that I say a lot is I just don't think any woman should ever birth a baby by herself. Okay? That just makes me sad to even think about it. Okay, it's very lonely and it's very scary. Okay, so get good. That's why we've got some volunteer doulas. We've got a volunteer program at a bunch of different hospitals. I think we're trying to work on trying to get some opportunities for everybody to have that experience, even located here, where you get to do some volunteer labor support and just helping people birth their babies. Some people don't do any preparation for childbirth. If you don't do any preparation, you'll come in just feeling, like you're not prepared. One big thing to ask them is, how are you coping with your labor? How do you think? Okay. Some women are feeling like they're coping fine, even though they're screaming, "Oh Lord, help me." That's what I have to do. I got to be allowed. That's just who I am. That's it feels normal to do that. In the doula program, we were showing a video, and like I said, some people yodel. Literally yodel. In between or during a contraction, and then they'll say, "Oh my gosh, I'm yodeling." Yes, you are, but you're with them, right? And it's just so funny. And can you imagine, right? If you've had birth, you've given birth, or you watch it, you are very vulnerable, right? You guys have been there, so you're very vulnerable, and you just have to go with it, and you want it to be over as quick as possible. We will look for cues that people aren't coping well, but again, asking them how they're coping is probably the best way. So like I said, maybe somebody who says to me, I've had people like, literally, okay, you remember how I told you I didn't want pain medication? Well, I want pain medication now. I lied. I really want pain medication. I lied. And then the partner will be like, oh, no, I think you really don't want pain medication. And then they'll be like, no, I really do. Like, what? So sometimes I'll get a code word that says that you're at the end. And if a person says to me, I want pain medication, I will not deny them of that. Even if the partner says to me, we do not really want pain medication. Okay? I will completely work with that person and say, if they have a code word, do we have a joke in the Twin Cities, or some giggling? No? Okay. All right. So if she says she's coping but you don't think she is, what can you do? You can help her. If she's hyperventilating, if she doesn't, know that she's not coping, just get her to breathe a little bit slower. Have her look in your eyes, and I'll just say, just look in my eyes and let's just start breathing here. Take a deep breath in, and what I usually say, just that last contraction, completely forget about it, wipe it away. Don't remember that. Just relax in between. Some people will fall asleep in between contractions. Okay, if they've got nitrous oxide that they're using for pain medicine, where that's that gas, similar to what we use sometimes in the dental office, but a lot lower concentration, then they'll kind of breathe that in, and then in between the contractions, they'll just fall asleep. Okay, just being aware of many different types of ways of coping. When they're not coping, people can claw at you, bite you, slap their partner, look panicked, grab people. I mean, I've had people do all sorts of things. And sometimes you just have to kind of peel their arm off and just say, okay, I'm going to need you to grab onto this pillow, or bite into this pillow, but please do not grab me. And very calmly, in between the contractions. And then they'll say, oh my gosh, I'm so sorry, I can't believe I did that. Who am I, right? People that have never swore, it's just not like them. I mean, you'll hear all sorts of things, right? You just take it in stride. It's like that, duck on the water. You act like it's no bother to you. No bother to you. You're just going to try to help. How can I help you? What can I get you? What we usually do is always go to the non-pharmacologic support, because we know you can do that right away. Ice chips, washcloths, massage, counter pressure, support, calming the partner down, all those different things. And then we'll move to pharmacologic and actually work to get that. It takes a little time to get that, so we want to work into that and be prepared for it. Okay? The big things we want to watch for is their birth plan. If they're really adamant about what types, they really don't want IV medication. If they're going to take any pain medication, it's going to be an epidural, stuff like that. Or absolutely no epidural. Maybe I'll take a couple bucks of fentanyl, or I'll try the nitrous oxide. So why is that important? That as a labor and delivery nurse, it's probably one of your biggest things you'll hear about after, is if you push pain medication on a person who doesn't want it, or you offer something that they absolutely don't want, you will get a complaint about that. Pain is, and how they anticipate pain and how they deal with pain is huge for them, so you have to watch their birth plan very closely. As a nurse midwife, I had to be real careful with all of that kind of stuff. It could be a real dissatisfier. Okay? I never cared how people birthed their babies. I mean, I had babies with an epidural and without. Okay? So I never cared how they birthed their baby. I just wanted to know how they intended to birth their baby and how well I could do that for them. Okay? In the quickest time possible. Again, safe for mom, safe for baby, right? And we want to make sure it doesn't interfere with the course of labor. Now, some pain medicines do. We'll talk about those in a minute. Some pain medicines will have an effect early on in labor, so I want you to pay close attention to this, because it's just important for you to know. In the early phase of labor, you've got some sedatives, right, that you can give, okay? But during active labor, you can do some narcotics, and you can do that intrathecal or that epidural, right? But look at how long you have to give narcotics, so like a fentanyl, right? Something that's going to take the edge off. It's fast acting, so that's great. But what can happen is that baby can have neonatal sort of resuscitation needs, right? Because if it slows the mom's heart rate down, right, and it slows the breathing down of the mom, it's going to affect the baby. So you only give it a certain amount of time. So it needs to be pretty remote from delivery. Now, sometimes they go faster and you don't really know, and you've just given a bump of fentanyl. What are you going to do? What are you going to have on hand? Does anybody remember what the antidote for a narcotic is? Narcan. You want to know that, right? You always want to know that. And we know that we have that available to us in the Twin Cities now for our friends that possibly are dabbling with, different types of drugs that we can help give Narcan, okay? We don't want to lose our friends, right? So this is really key, and it reverses it right away. Okay, we don't give it that often. We want to make sure we assess to make sure we can't help with resuscitative efforts. Okay, and then with the transition phase, you'll see that we just don't do anything other than a narcotic or anything other than epidural or intrathecal. Okay, in that transition phase, and then after that phase too, you don't give anything other than a local infiltration, so a 1% lidocaine. I like this slide because it kind of just shows you when things can be given. It's kind of a good one to put things all together. Let's talk a little bit about a few more meds just in between this. So for your narcotics, you've got some sedatives and narcotics that you can give. We give these very, I would say, not that often. Okay, the biggest one we're going to give is usually a morphine or a fentanyl. And the early stages will give maybe an Ambien to help them sleep. If they're one of those people that have come in and they've got those hypotonic contractions or hyper, and it's just long periods of time. Okay. If you give too early the morphine, it's going to slow your labor. Epidurals will also slow your labor. Okay, so they'll be having great labor, no oxytocin present, and then they take an epidural and it'll peter out. It'll usually start up within the next hour, but sometimes our providers don't want to wait that long, so they'll give them a little bit of pitocin or oxytocin to help with that. Okay. Let me make sure. Okay, got all that. Phenergan and Vistarel, they used to be a combo given. It lasts longer than we like. It can cause people to hallucinate a little bit. Feel very anxious, so we really don't give that very often, but there are some places that will still give it if they're having a real tough time. Not very often, so I want to make sure you knew that. The key with narcotics is that they cross the placenta. Okay, so go straight to baby. Right? So the biggest things that we want to note about that is mom will feel dizzy. She'll feel very sleepy. She might have nausea and vomiting that happens as a result of it. She'll have tachycardia and hypotension. The baby will have decreased variability, so that, remember when that blue line, I was talking to you guys about the fetal monitoring strip? We like it to be bouncy and the heart rate going all around. These are babies that have just really straight lines. It mimics sleep on the baby, okay? We know it's okay because we know we've given a narcotic. We understand that baby is sleeping. We like the baby then to wake up in about 20 minutes, okay? It might take a little bit longer, but these are very fast acting. And so then the baby will jump around and be all happy again, and then we can give another dose if we need to. So we monitor this in between. Again, Narcan is going to be your quickest reversal. Okay? All right? The reason why I have that last very small bullet is it's not as recommended anymore, okay, with babies. So just getting them awake pretty quick, we can do that pretty quickly, okay? Only if a baby severely has severe respiratory depression will we give it, okay? But it's always there if we need it. It's contraindicated, though. I want you to make sure in somebody who is using narcotics as a form of drug therapy, or I should say recreational therapy, okay? So if you give this, it can precipitate a drug withdrawal that not everybody's prepared for. That's the main reason for this in babies as well, okay? Which a baby that has NAS scores, so the neonatal abstinence syndrome from a narcotic, is a very upset baby. Okay, and that happens anyway. When we know that our moms are using some form of drug, we already know this baby's going to have quite a big wake-up call. Okay, there are ways to give them a little bit to sort of help them along and get them so that they're not in such bad withdrawal. But these babies are not happy, and they cry all the time, and they don't eat well. So it takes about 4 or 5 days. Okay, it's a real tough thing to watch. All right, the types of regional anesthesia, right? Regional anesthesia is something that we train you guys on just to know what it's about, but most of the meds, I would never have you understand the mechanisms of action because the site, the epidural space, is not your scope of practice, okay? You guys are trained in peripheral IVs, sometimes, remember, central lines. We've talked about this before. If you're a highly trained nurse in terms of an ICU or in some other place, you'll get higher training, but you'll never get training in an epidural space or giving meds in an epidural space because you need to be an advanced practice nurse or an anesthesiologist to do that. Okay? I only tell you that just because I wouldn't expect you to know the meds. Okay? The biggest key for this one is the hypotension that happens for this. So they're going to always get some extra fluid, and we'll always have some different medications to get the blood pressure up ready. Okay, the fetal heart rate has those same changes. So we're going to watch them very closely. You can have some respiratory depression with this. Mom can if it travels too high. We'll talk about that. Mom can get very nauseous from it. If fentanyl is in the epidural, she'll get very itchy. Okay, so fentanyl given IV or through the epidural, the biggest side effect is pruritus. They will literally scratch their nose off or their face, and we'll have to put some gloves on them, or just have them just breathe through it. It's incredible itchiness, incredible. Scratch their bellies off, okay? Do as well. So you really watch them closely. And it usually happens after birth, really severe as well. They'll get the shaking and then the deep, deep itching. The biggest thing with epidural is urinary retention because they can't feel it. They have to go potty. So you have to watch that real closely, okay? So a Foley catheter, straight cap, oftentimes, but if they're remote from delivery, we'll maybe put a Foley catheter. We'll weigh the risks and benefits of that. In order to anticipate hypotension, I already stated that we're going to give them 500 cc's at least a bolus. If they do start having it, we're going to reposition them and get them on their left side. We'll give them some O2, maybe give them a vasopressor like ephedrine. Get that, and that's not me getting it. The anesthesiologist is present with us when we get or a CRNA, when we do an epidural. And we will stop the oxytocin. We'll get the providers there if needed. Usually this is reversible. It happens quite frequently, so people are prepared. You need to document very, very closely what's happening. These are the type of patients that are getting blood pressures every 2 to 5 minutes in that 30-minute time frame. What's the biggest key as a nurse you have to look for? I want you to remember this. You're monitoring an epidural. It is what? Blood pressure, and what's the other thing? Respirations. Thank you. Blood pressure, respirations. That's your main keys that you will be monitoring them for. Okay? Let's talk a little bit about an intrathecal space here. Where is that located? Okay? That is located by the spinal cord. Okay? So there's 2 spaces. You've got the epidural space and intrathecal. Look at how small that epidural space is. Now, is it common, do you think, to go further by accident into the spinal space there? Yeah, it is. Especially if mom moves. So she's rounding. I'll go to the side. She rounds her back, opens up her space back here. We actually tell them, do not move while we're placing it. So that happens, and they're trying not to move in between a contraction that they're literally trying to breathe through. So this big, long needle doesn't go too far, and sometimes it does. So there's a sweet spot. Okay? You can see how small it is. If it does go too far, they have a high risk of spinal headache. And you won't know that until after about 24 hours. Okay? So one of the things I want to make sure you guys remember is if you're watching an epidural for the first time, it's kind of like watching a C-section. It can be quite overwhelming. The needle is very long, and it can affect you in a way that's kind of you're not prepared for. Okay? That's when most of the time we see our partners go down. Because they think, oh, I can handle it. I'm an EMT. I'm this. I'm that. I've seen everything, right? And then they're like, oh my gosh, right? It's the stress of the environment. It's their loved one experiencing this. It's a bunch of things. Okay. So don't think if you're going to have an epidural. Usually, you know that that's going to happen. Remember when I told you guys to always have a bar that you like, a protein bar, something in your pocket. This is one of those times where you run out and you say, I'm just going to throw half of that bar in my mouth, and I'm going to drink some water, and I'm going to go back in, okay? Or if you anticipate already feeling a little anxious about it, I wouldn't watch that, okay? Not for the first time. Kind of wait a little bit of time, okay? No, if you feel that way, we did have a couple people that did experience feeling pretty lightheaded after it, so I'm just warning you of that last semester. Okay, what do we give in an intrathecal? We give fentanyl and morphine, but the key about an intrathecal is it's one dose, not a continuous one. So that's what I want you to remember about that. It lasts about 2 to 6 hours. The timing of this is very important because we only give it once, okay? We only give it once. It's not like you can go back in and do it again, okay? It's just a one-time shot. However, because of the space that we're giving and where the location is, it doesn't bathe really as low in the sacrum as we want, okay? So they're going to feel a lot of pushing pain, okay? Sacral 1, 2, 3, and 4 are going to be pretty alive. It's the epidural that kind of gets in there, okay? Make sense? All right, let's move on. All right, let's talk about this epidural. Okay, this is that continuous infusion via catheter. It's given usually, right around active labor, but some people, like I said, remember that third of people will say, hey, I really want this early. I don't want to feel any pain. Now, the problem with that is if they have no labor, there are people that will do this, but if they have no labor, what happens to that baby? Right? It stays high, because if you move around and you're in active labor, that baby's going to move down a little bit. So then I've got pain medicine and I've got a high baby, so it's going to take us a lot of time to get that baby down, and she's stuck in bed. The best thing that we can do for women is to get them to move, okay? Get them to move. Our patients need to be in different, when you're in actual active labor and don't have pain, you naturally go to different positions, but just naturally you're just so uncomfortable. You kind of find yourself pacing that it'll move that baby on its own, okay, down. But if you're stuck in bed, then these patients have a harder time. All right, so given an active labor, what else? And the hypotension is profound on this as well. Up to 1 to 3 liters, or just giving a lot of fluid in between. That's why you're at risk to have that bladder fill up pretty quickly. Okay? Most of our patients come in that they're pretty dehydrated, or they're in labor for a long time, so they haven't been drinking well. That's why we give them some extra fluid. It's always a volume expander, so it's going to be a LR or something like that, where there's nothing in it, so that if we need to expand, we can. All right. So just where it goes in, I just want you to pay close attention. L4, L5 is where the epidural space is located, where we usually go a little higher than that, because remember that pain starts at L1, so we're going to go a little higher than that. All right, and the spinal space is a little bit lower than that. Okay, and that's just because of the location and where we can get into the spinal space. Okay, although some people have some pretty constricted spaces, so they might adjust that a little. Okay, there is an immediate effect, pretty immediate, with your intrathecal. The epidural takes a little bit of time. We do a bolus, and then we do a maintenance. That maintenance can be delivered in a continuous or in a basal rate. It can also be done in a patient-controlled epidural. Okay, I don't remember how they do it here, but I know in the Twin Cities we have quite a few places that have moved to it. That allows them to move around and have what's called a walking epidural. Okay, where they have more space to move and they're not as numb. Okay? All right. So remember what those space looks like, right? Okay, so let me just teach you a little bit about this. When you go into the epidural space, you get a flashback, you get the nice clear fluid, and that's when you take, there's a threading, you take the needle out and you thread the catheter. The catheter is long and it has holes all the way up it as well as holes at the end. Okay? It used to only have this little hole at the end, and then they changed it where the catheter actually has holes all the way up, so it just bathes that area on both sides. Now if it's kinked to right or left and you thread it, it might be right or left on the woman. Okay? That patient might have an experience where, oh, my right leg is just total bum, or my left leg is bum, a bum leg, and the right leg can move. Okay? Now there's nothing we can do. Okay? We can't go back in and pull it. All right? Sometimes they can re-thread it. That just is so much pain for them. Okay? So sometimes they'll just be like, no, just leave it. Okay? So it's kind of a bum deal because those new catheters should bathe it really well. Okay? But sometimes we get a right or left-sided. Okay. Positioning, you can either be sitting up or lying down. Okay? Yeah, and whatever you do, you just open it up. You round around your baby as much as you can. Kind of curl around the baby, okay? All right, this is important to note. So what we do is we keep them in a little bit of a flatter position for the first 30 minutes, and then we raise the bed quickly. We do not want this to become full anesthetic, right, that you would have a surgery, right, for. So we don't want it to go past the breasts, okay? If it does, what's going to happen? If it goes past that area, what's going to happen? Respiratory. And that does happen, unfortunately. So we're going to be watching very closely for that. That's why you're in charge of respirations and your blood pressure vital signs, the baby, and all that, okay? So we don't want it to go very far. Now, when it does, they know it right away. They start looking at you panically. They panic. I can't breathe. I feel like I can't take a deep breath. Usually, if we pull the head of the bed up into a higher Fowler's, we don't want to go too high. We go, that'll relieve that a little, and it'll kind of come back down. This is where you have your anesthesia partners in with you. You can do a couple different tests. NICU level, you can test the level with them. They can ask you to do that. I usually have somebody in with me verifying the level. Okay? And it's usually with a cotton ball or something like that, or some way to test that. They can feel that. Just that a couple different things. You just want to make sure that you are monitoring the level, right? But the big thing for you will be Kia's respirations, right? Anything lower than how many? What's too low? What's the normal? Respirators. Can we remember? Oh, yeah, great. So anybody lower than 12 is going to be 10, 10 or 12. It's going to feel pretty bad, okay? And if a mom and that parent is not able to actually breathe, right? Take breaths, what happens to the baby? Then the baby can't, so then we've got that heart rate issue for the baby. That's why that blood pressure issue is key. Watching the blood pressure of mom is going to let you know about blood pressure of baby. It's a little delayed. Blood pressure of mom goes down, and you'll see in a few minutes baby's heart rate will go down. Okay? Ephedrine goes in, blood pressure comes up, babies will slowly come up. It's usually a good long dip though. So we watch it 100% one-to-one nursing at this point. First 30 minutes of an epidural, one-to-one nursing. Okay? It's usually that way anyway in active labor. Some of our hospital sites will allow you to have somebody who's in early labor and just beginning active labor, but once it's full-blown active labor, it goes to one-to-one nursing per our scope of practice. Sometimes you go through that epidural space to the spinal space, and you might need a blood patch. I just wanted to show you that picture, and that's where you usually find out in the postpartum period. Does anybody remember what it feels like, or what you know about with a spinal headache? I've had one. Anybody had one? No. Okay. What happens is the leaking of the spinal fluid around the brain is occurring, and it's pooling in the back of your back. So when you sit up, it's a headache that will never, it's unbelievable. Pounding, pounding, pounding. You lay back down, it's relieved. So the only thing to do, it will not solve itself. You need to do a blood patch. And so why they call it that is they pull some blood from your own arm, and they create this patch, and anesthesia comes in and does it, and it's an immediate relief. Immediate. Okay? So sometimes we wait too long on these, and I just don't know why. It's an immediate relief. And the way you know it is they lay back down, it's relieved, they sit back up, and it's not. Okay, literally the base of the brain is settling down here at C1. Okay, and that's where the pain is coming from because of the leaking of the fluid. We can't keep up on it. Okay, we're not making it as fast as it's being released. All right, so let's just talk about other anesthesia, right? To just get a little bit of numbing. That's that local infiltration. That's what I talked about when you get like a tear or an episiotomy. I'm going to be repairing that way. The other way is a pudendal block. I'm going to show you a picture. We don't give it as often, but some people are trained to do it. It's actually a way to give pain medicine at the sacral level where that vagina is and the perineum, okay? And it's a very long needle, and you have to be real good at finding your location, okay? It's something you don't just try once. You need to be good at this. And then, of course, cesarean birth. You're going to need general anesthesia sometimes, but you can most likely do it under a spinal or an epidural, right? Because remember, spinals last 2 to 6 hours. That'll be fine, and epidurals can last as long as we need them to. We want to make sure that mom, if she has a potential cesarean birth, that we are going to make sure that her gastric all in her tummy is emptied, right? Her stomach has to be emptied, okay? If somebody comes in and is a scheduled cesarean section, we're going to ask them when their last meal is, because it takes about 8 hours for that meal to leave. In a normal person, about 3 to 4. Okay, so it's very slow in a pregnant person. Why is that? Because there's a risk for gastric aspiration. Okay. Oops, I did that again. Okay. So what does a pudendal block look like? That's just the best way to describe it. You actually go and find the pudendal nerve, and it's located right below the ischial spine. And then you insert the needle and give the pain medicine. You have to find it on both sides to get equal amount of pain relief. Okay. There is a trumpet, which is what the needle guide is, so that can be done. There are people that still do these pretty routinely. Some people that have been doing this a long time, and they find it really works well, especially if you've got a 3rd or a 4th degree laceration that you have to repair. Okay, so it's long repair. Pretty amazing what some of these pregnant women, people go through, right, to have babies. All right, so what are the types of analgesia after labor? Just real quickly, we can give Tylenol and we can give ibuprofen. Ibuprofen is a magical medicine after birth. It's all you need. You do not need narcotics. Because why? Because ibuprofen works on muscle pain. You think about Tylenol. Tylenol works on incisional pain. You can alternate it if you've got both, the uterus cramping issues, and then you've also got a tear that you've repaired. You can give 2 ibuprofen, and 4 hours later give, a Tylenol. You can alternate these, okay? Right? Some people go up to about 800 at a time. That's a lot of ibuprofen. Most people don't need that much, okay? Right? And there's a warning on how much Tylenol you can give in a 24-hour period, and that's 2,000 milligrams, right? So most Tylenols are 500 milligrams, so if you alternate them, every 4 to 8 hours, you're going to hit that pretty quickly, all right? It's always good to also understand where things are excreted, okay? That Tylenol is in the kidney, right? Ibuprofen's in the liver. Okay, how are they excreted? That's why we can give them. We can even give them at the same time. Okay, but it's good to alternate them. All right, so what else do we need to know? Let's see. Cesarean section, you can also give narcotics after. You can give them a little bit to get that pain level up. You can give Toradol, which is IV, which is your IV med that's going to be similar to your ibuprofen, so it'll work on muscle pain. And then right as soon as they're off of, they're about the first 4 hours after birth, after a cesarean section, we're going to move them pretty quickly. As long as they've got some vowel sounds to eating something, once they're taking POs, then we'll just give them PO meds. Okay, if they can tolerate POs, we'll give them PO med. Okay, you cannot do an IV med and a PO med. Cannot do those types of pain medicines together. It's either one or the other. Okay. That's all I have for that. That's exactly when I wanted to end. All right, so what we're going to do now is we are going to look at the fetal monitor strips, okay? And I'm going to spend the next 15 minutes, we'll go through a few of them. Now, I'm doing this because I want to do a few things. I want to alleviate stress for you, okay? Because I don't want you to be too worried about this. And make sure we understand the context for which you guys will be needing to understand it. So a couple different things. Let me get this pulled up. All right, how do I... Okay, a couple different things. When you're looking at the fetal monitor strip, the very first thing you're going to see and ask yourself is, what is the baseline of the fetal heart rate? Okay? That's the very first thing you're going to say. Now, people used to say, well, no, I really want to understand variability first. How many little bumps are happening? Nope, you want to understand baseline first, because once you get baseline, you'll understand your variability a lot differently. Baseline's first, then variability, then do you have X cells or D cells? Okay? Now, how many of you actually did some of the worksheets? So, because what I'm saying to you right now might sound a lot like a foreign language. Hands high. Good. How many in the Twin Cities? I can't see the Twin Cities. Ryland, can you let me see?
Fair amount.
Fair amount? Okay,
yeah,
good.
probably about 70, 80%.
Okay, good. So all I need you to have done is really practiced it. Like, can I figure this out? This is a higher level of learning. It's actually an advanced learning that you usually will not get certified on unless you have 2 years of labor and delivery. That's why this context is just mostly to alleviate any stress. But I think it's really important for you when you go into labor and delivery and you're looking at the strip and all of a sudden you say to yourself, wow, these are too many contractions, or this variability doesn't look good. Okay? Things like that, and talking to your nurse about it. That's why I give you a little bit of context here. Okay? All right, so we're going to look at the first one. What do you guys think the baseline is? Just showed you. We didn't see that. What did everybody have? How do you tell the baseline? Now, if you drew an imaginary line and you kind of put it in the middle, right, the median, right, of this strip, what would it be? It's usually a hard number. It's not like a rounded number or anything like that. So 135 or 130 or 140 or 145.
So it's 120 to 150.
So the variability is different than the baseline. So what Dr. Beecham just said is, where are the bounce? How is it where is it going in between? And we're going to talk a little bit about this. So what's baseline? What would you guys say?
135.
Yeah, that's right. Some of you might have seen it, but yeah, 135. Now if you put 140, right, some of you might say that. This is not like a right or wrong answer, but when you get better and better at this, you're going to be within 5 beats of variability. The cool thing about these monitors is they're called third generation monitors, meaning their beat-to-beat variability is really accurate externally. That's pretty cool, because internally it's 100%, like, you know, every single beat. This is actually pretty similar to that. Okay, so the reliability of what you're seeing here is pretty good, as long as you have fetal heartbeat. Can you pick up mom's through this? Can you pick up mom's heartbeat? Yeah, you can, right? So when you first get a fetal heart rate, you're going to want to do a pulse on a mom. Okay, and moms sit right at about 80 to 80 and 90, 60, 70, 80, 90, something in there. If they're in labor and in a contraction, it could go a little bit higher. Right, but it's never going to sit at 130 unless she's got other issues. There have been cases that we've monitored a mom and a baby wasn't doing well. So there are cases like that. That's why you have to make sure your pulse is documented. Okay? All right, so what's the variability here? Is it absent? No. What is absent? 0, right? 0. Is it minimal? What's minimal? At least 5. So, like Dr. Beecham was showing when she said about 120, in that 1 to 20, in that area, that's showing the range. So this is what I'm talking about, the variability range. So this one is definitely not minimal. Okay? So what is it now? What's the next range? Is it moderate?
Yes.
I would say it's close to moderate. Like I hadn't looked at all the answers. Yeah, moderate. So there's at least 10 beats of variability here. And I just showed the answer. So at least 10 beats of variability. Why is that? What am I saying? What am I saying? They already care. So it means that the fluctuations of beat to beat, where it's going up and down, just like you and me, right? Right now, as I'm teaching, I'd have at least 10 to 15 beats of variability in between my heart rate when I talk loud and when I talk slow. This is that baby's variability. Moderate is the sweet spot. Okay? Right? Anything above 5, all the way up. Okay? Now, sometimes they can be marked. That's greater than 25 beats of variability. Those are babies that you either think are in, maybe you just drank some juice or they have a lot of sugar on board right away and they'll be it's almost like a hyper, but then it'll settle itself down. A baby that has 25 beats of variability or greater for a long period of time, that is not good either. The sweet spot is moderate variability. Why? Because it tells me that the baby is well oxygenated at this point. No baby can give you moderate variability if it's not well oxygenated. Okay? All right? And in the same inverse of that, you only have about 30 to 60 minutes with those contractions being too many for that heart rate to come down and not have good variability. Okay? The beat-to-beat variability is key here. So you do baseline, and then you find the beat-to-beat variability, which is about, at this point, in between fluctuations of about 10 beats per minute, and that equals moderate variability. Okay, now let's look at, do you see any accelerations? What are accelerations? It's anything that's, your baseline is 135, so the acceleration has to reach 15 beats above the baseline for 15 seconds. So you have to just look at this and say to yourself, are there any accelerations present? And I see a couple. Let me see. Okay, yes, 15. Okay, so there's a couple of them here. And I would say, if you can see my cursor right here, I would say this is one because, right, if your baseline's sitting at 135 and through here, this is at least 15 up high and it lasts for 15. So you have to draw a square there. That's called an acceleration. Again, the fetal stem, the brain stem of the baby. If it's not doing well, it cannot accelerate. So it's another way of us telling you the fetal well-being is good. All right? So, got that. All right, let's just do contractions here, because I don't want to spend too much time, because that's all I need to know. Are there decelerations? That's one other thing. Are there anything left going below the baseline? Not too much. Not anything that's rhythmic or looks like it's an issue. Okay? Why is that? Because even a variable deceleration has an abrupt descent that's at least 15 beats, and it lasts for a little bit longer than 15. None of those are happening. There are some that go a little bit lower than 35, but not for long, not for 15 beats, right? So that's not a variable deceleration. There's no earlies present, and there are no lates, and I'll talk to you about that in a minute. Now let's look at the contraction pattern. How many contractions are there? Total. That you can see pretty well here. 4. Yeah, I would say 4. You got another one on each end, right? All right. So to tell how many contractions, how often they're happening, is the beginning of one contraction to the beginning of the end of another. So how often are they happening? If every red line here, or every big, depending on how you're looking at it, is 1 minute, the beginning of one to the beginning of the next one. What'd you say?
Every 2.
Yeah, every 2. Out every 2. All right. Now I want you to tell me what the resting time. Well, first let's do resting tone. What's the tone? What is it sitting at? Can I walk over there? Can you see me? I'm going to walk over here. What's the tone here? What's it sitting at? If this is 15. Yeah, about 10. What do we not like it above? 20. We kind of give a little bit of range. 10 to 20 is kind of where I sit, kind of happy. Anything above 20, I don't like. All right, what's the actual resting time in between? So the contraction comes down and sits at the baseline for how long? So this is 1, 2, 3, 4, about 5 seconds, or 5 bars. So how many seconds? 50. Is this long enough? No. This one isn't. So let's go to the next one. All right. How long is it here? 1, 2, 3, 4, 5, and a little bit of this one. So maybe close. It's closer. Okay. So if I have 60 seconds, right? What did I say? The baby can breathe, right? Yeah. What about this one? Okay. Here's that peak down. 1, 2, 3, 4, 5, and a little bit more. So what are we thinking? Is there enough resting time here?
Not great.
Not great. Now why? So I'm going to throw a little bit of a wrench in here. Okay, a little bit of physiology. This is my life. I studied contractions and taught about physiology of contractions for years. In the first stage of labor, so I want to know what stage of labor this is before I would make a thought process around this. But in the first stage of labor, I know that they need to be at least 60, and the research showed about 63 seconds for the pH to stay normal. In the second stage, the way that our bodies work is that they get a little closer together, okay? And they can be at around 45 to 50 seconds, okay? But if this is constant at this stage, at this point, this looks to me that this is obviously early labor, because I'm not seeing anything else going on. This is going to be too little. Yeah.
Where you start counting the seconds?
When? Oh, this one? Well, the resting time has been right at around 15. So this has still got some pressure to it. So I'd go right in through here. And then it finally drops a little bit more. Yeah. This one's a tough one, because it goes back up. I might even start here. 1, 2, 3, 4, 5. Yeah. So this one is moving into tachysystole or hyperstimulation. Okay? These are too long of contractions. Let me just, sorry, Rylan. Let's just show you how long these are. 1, 2, 3, 4, 5, 6, 7, 8, 9. This is 90 seconds. When you're going through labor, this is a hard contraction. When you get, these are about the same length. But this one, what's happening to her at this point is she's probably pretty irritable by that time, because she's not getting a full relief. Okay?
So does it affect the top of the baby?
It does, yeah. So, but look at this nice baby. This baby's like, it's a little bit, it's jumping around nicely. This is gonna last how long? Remember how long I said? They can handle this for quite a bit of time. How long can they handle it? Too many contractions. About 30 to 60 minutes, they can actually handle that. It depends on what's happened before or after, but this can be very detrimental. You'll start to see a couple patterns here. Let me see if I can't show you one that's not very good. Let's look at this one. No, it doesn't say this here, but you have internal monitors here, and the only reason why I know it is the way that the pattern looks, okay? The real smooth lines of the contractions in IUPC. That just comes from you knowing that, okay? Let me see if it says it at all here. Oh, good. All right. So what do you think the baseline is? This is a pretty easy baseline. 150. Good. What do you think the beats per minute? What's the variability? Yeah, is it absent? No, there's beats there. So is it minimal? 0 to 5? Yeah. What could we be thinking about this? I just taught you about this today. What are the two things you're thinking? Is it what? What's innocuous? Sleeping. This could be a sleepy baby. What's not innocuous? What's something that could be happening here? Narcotic, right? Narcotic will cause this. Magnesium sulfate will cause this. What other things can we think about? Lack of mitoxicity if you're at the end of this, where you've got no oxygen. And then anything that the mother's doing drugs. Okay? She comes in and this baby's looking like this, and it lasts longer than 20 minutes. I only give them 20 minutes. That's how long they sleep, 20 minutes at a time. Okay? I know I'm running out on time. So that's that. And then what's the contraction pattern here? Are there any decelerations here? No. Are there any accelerations here? No. These babies do not decelerate, and they usually don't accelerate well with very minimal beats of variability. Why? Because they're not reacting to anything. These are the types of babies that, you're running down, an alleyway with even a knife would not react, okay? Nothing will cause them to react. This is not good, unless it's just a sleep pattern. Then you can give them some juice and wake them up and they'll get happy again. These babies, you could do fetal scalp stimulation. You could try everything, they would not react. Not react. Totally out. Okay, not good. What's the contraction pattern? How many do you see there? 3, a good 3, 1 of 4. All right, does this look like a good rhythmic pattern? No, this is a crappy pattern. This is not going to do what I need it to do. I need them to be more rhythmic. I need them to have some good, not too long a spacing in between. So what is the rate? How many are you seeing? How many contractions at a time? Or, per Q? Need me to help with that? This one's kind of hard. Yeah, so you've got one that's happening. So this one is 1 minute, almost a 2-minute contraction, 2.5. Really, this is not a good contraction. This is painful. So this is one, it's kind of 2 to 3. So that's 3. Then this one started this one to the next one is 2. Then the start of this one to the next one is what? 1, 2, 3, 4. So what is it? 2 to 4. Yeah, that's how you say it. And that's okay to get contractions in a range. All right. So let's just look at some of the complications of this one. We do categories as well. I'm not going to expect you to know that. This could be fetal sleep. Some of the patterns, like if you were saying, if you're already filled without sedatives, narcotics, magnesium, just like I said, alcohol or illicit drugs. Okay. Tachycardia. This is close to, it's 150, but maybe they had some tachycardia and came down a little bit. Maybe you might see some decreased variability from that. The other thing that you might see this with is any gestation that is lower than 28 weeks. So this can be, we don't monitor those babies very often, unless we absolutely have to, just because we know they're not too reliable. We'll want to know there is a heartbeat, but not put them on a monitor for very long, because we know that their fetal, the stem of the brain stem isn't fully developed. The worst cause of this could be hypoxia, like Grant said, so it could be that the baby's not having any oxygen, which would be not good. That could result from whether the placenta separating or the uterus is rupturing, something like that. You'll see these patterns. Or it could just be an abnormality of the central nervous system where this baby's brainstem is just not functioning well. It's term, but you know that we haven't given any narcotics, magnesium isn't on board. No, there's no reason for this. It's not in a sleep cycle. It's longer than 20 minutes. You got to assume you've got some other heart defects, or you've got a brainstem abnormality. Okay? All right, so let me just see if I can't get to one that is, let me get, that one's a rhythmic pattern. Nope. Do one more. Oh, okay. Okay. So this one, I just want to do really quickly. Now, what is the baseline? We have 2 minutes, 1 minute. Okay. See that up there? I can't even reach it. 120. This is 120. So it's higher than that. What is it? 30. It's actually 150 up there. So that line that's straight at the top is your baseline. So anytime it's straight at the top, it's your baseline. That's why I wanted to point this one out. Now these things that are dipping, what are they called? A deceleration. What do they look like? Does anybody remember what this one looks like? If it mirrors the contraction, coming down at the contraction period, what is it? Early. It's an early. Good. If it happens after the contraction, what is it? Late. Let me just show you one picture of that, and then that's just, again, you're just going to have to know what if it's a fetal monitor strip and whether you've got too many what you got. I'm not going to ask you to interpret too many different things. All right, those are variables. These are called variables because some people say the best way to tell this is because it looks like a V, but this just means it's variable in time and shape, and it doesn't last the whole contraction or just go down in a rhythmic pattern of the contraction. Okay, but then let me just show you this last one. That's what a late looks like. Those are late. Now see the contraction and see when the baby's heart rate goes down? This key is going to open up with you, so you'll have this. But just for fun, for those of you that really want to do this, you see how the deceleration comes after the contraction? Yeah. Why is that? That's ureteral placental insufficiency. That's a baby that is not reacting to the milieu that is happening inside of it. It's happening after, which is not good. This is not a good pattern. This is a very concerning pattern. Its fetal heart rate is high. It has very little variability, and it's got late decelerations and too many contractions. This is a baby you're not going to watch for very long. Okay? All right? So that's one that's what we would call an abnormal pattern or a category 3, and it requires by law, in order to keep practicing, to do something about it. C-section, oxytocin off, those kinds of things. All right, it's been a great class. If you guys have any questions, then you can email me. Okay, really quickly on the test. Usually about 5 to 6 questions per thing that I've talked about, so no more than that. People have been asking me, is there a study guide? The study guides are your PowerPoints. Okay, that's how I do it. Okay, that's how I break down all that reading, all the stuff from ATI. And figure out a way to hone it down for you. Do you have to read? You do. You do have to read. But I know you guys have at least skimmed that, and come to class. The recordings, I think, are going to be helpful for you if you feel like you're kind of missing some areas. What other questions have I missed? I had a lot. Those are the types of things I had at the break, so I want to make sure I stated all that to everybody. In the Twin Cities, do you guys have any questions?
Doesn't look like they do.
Okay. I have one here. Yeah. Yes. Case study key will open up. They always open up at the end. So.
What was the question?
If the case study key for post-term pregnancy will be up, and it will. I also put together that Stages of Labor guide, and that might be helpful for you for just looking at that as well. That was new. you guys. Okay. No questions? Okay, thank you.
Thanks, Dr. Summers.
Thank you.
It doesn't feel
They went to Starbucks, we're going down to French.
I'll walk down there.
But I only